cloth, like a kitchen cloth. It's very gentle on the tissues. And I see the team there is annotating, very gentle on the tissues. And because Dr. Omari had already highlighted that the structures here are very sensitive structures. You don't want to be rough with them. So you want to stroke them and tell that peritoneal flap, come down slowly. You tell it nice things and it listens to you and it comes off. But the second thing is, when you have even small bleeding, oozing, the red, in laparoscopy, what happens is, because of principles of light is absorbed and it gets darker. The more blood is there, the darker it gets. So you just want to be, once you wipe off the red of the blood, your field becomes clearer. So a bit of principles. Encourage your children to do physics because it's necessary in medicine. That's part of what we are seeing there. Any other questions?
There's gotta be. Hello. So you're hearing Dr. Omari from Coast General Hospital, Mombasa, for the new people who have just arrived. And you're seeing a laparoscopic hernia case that's being done. And would love to put to the audience any questions that you've always had about anatomy. Yes. Oh, hello, ma'am.
Thank you very much. My name is Sophie Onyango. I work with Safaricom and M-Pesa Foundation. I'm very pleased to be here. And I'm not sure whether this question has been asked before because I've just walked in. But my concern was, and when I was invited for this session, I said I want to find out who takes care of the professional responsibility if anything goes wrong during the surgery.
Fabulous question. I love this. People are very engaged. So, how the contracts are is that the hospital itself owns, first of all the data. No one can get access to the data unless they ask for permission from that hospital. Also, when you sign the contract, the surgeon operating with the scalpel is 100% responsible for that surgery. So what we utilize this for is not when a person is untrained and not able to do a case. It's when, let's say, Dr. Muthoka, I'd love for you to share it. This is a neurosurgeon from Makwini County who does cases weekly on Proximie.
All right, okay. Oh, that's good.
Why did you dial Dr. Okanga in from Coast General? It's not because he's not able to do it, but...
To the surgeon and then...
Okay. Hello, everyone. So...
the case is already going on.
Okay, I can. So when I went to Makwini County, I realized that they were actually equipped with this technology. So what you asked, as far as professional responsibility, the consultant, the one who is doing the operation, is licensed to do it. So he's responsible. If anything goes wrong or anything goes unlike what he expected, it's up to him. Then also, that's the professional responsibility for that case rests on the consultant. Now, as far as data protection, that's what I think Shannon was alluding to. The data it belongs to the hospital and more so to the patient. So you cannot switch on those cameras if the patient expressly said, don't. Okay, so there has to be consent. Part of your consent form, as they're accepting surgery, you also intimate to them that you have cameras in theater and that you will record. Are they okay with that? Why are you recording? There's a patient who asked me that. I said, first of all, to review myself, to see what I am doing and whether I'm doing it right. Number two, I can invite my colleagues to watch. So last week, I had a case that, it's not that I didn't know what to do, but I was dilly-dallying with a decision. You know the way decisions are final in theater. So when you're doing it, you have to do it finally. You're not going to have a second chance to do it. So there was a 2.5 centimeter. I was cutting somewhere in the head. I'm a neurosurgeon. So I was doing a craniotomy and I was fidgeting with how far to cut the bone. My colleague, who is my senior, was listening in from Mombasa, but I was in Wote, Makweni. So I called him. We reviewed together while I was operating, and he gave me an instruction. He's my senior. So he told me 2.5 centimeters above somewhere. So I was able to make a quick decision. If I was alone, I would have taken maybe 20 minutes fidgeting, thinking about it. But I have my seniors joining into the surgeries. So there's peer review of every decision, and it can be defended professionally. Yeah.
I love Mathoka. Oh, wow. More questions. Okay. Start here.
Hello, good afternoon, everyone. My name is Moses Wawero. I work for a company called Vilgrow Africa, and we invest in early stage companies in the health and life sciences. This is the sort of thing we invest in. It's really quite impressive. So I have a bunch of questions. Start with a comment. How is this patient doing? I'm curious. The other part is two questions. How do you tell the surgeons on the other side in advance that a surgery will be taking place? Do you schedule so that they're prepared to join in? Or do you just call them? I would like to understand that bit. But the other and probably more important question for me is who pays and how is the payment done? Who pays for the team that's joining in online?
Okay, so first and foremost, great questions, and thank you. Venture capital in the private sector is so important to healthcare. I think we need to underscore that. Private-public partnerships are what are going to make things happen into the future. So thanks for attending. First and foremost, when we talk about calling, you can schedule a case on your calendar on the Proximie app. So that really easily allows you to invite people, click, 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 who you want to come join and alert them. And they get an alert in their email and a bing, it comes up. We've got a new WhatsApp feature that's coming as well, that straight to their phone, they're going to see that and they can start to collaborate immediately. The second piece is you were asking about who pays for the clinician on the other side. Currently, this is a part of the Surgical Society of Kenya, and I want the president of the Surgical Society of Kenya to come on up and share how it's been working to date, but then how it might work into the future.
Yeah, thank you. So it's a really good question. And when we were setting up the partnership, we actually have a mechanism. So essentially, we agreed that we would install these systems in our theaters. And then secondly, the other bit of this is when you put the system in, somebody has to use it. And so all the surgeons in the different hospitals now signed up, and you have to go hospital by hospital. So each hospital runs its facility differently. You have to get permissions from the medical directors, whoever is in charge of the leadership. But for now, what we do have is that, like Mudoka is in Wote, has a system. I have one where I work. They have one in Coast General. Joe TRH just got one. And so as a society, we are asking, how can we leverage these to upskill? So now what we've done is we've created what we call digital communities of practice. So I'm a minimally invasive surgeon, so I schedule my procedures, and then surgeons say, I will join you on Thursday at 8 a.m. And you see, it's very flexible because I can join on my schedule. What we are telling the hospitals is there's an infrastructure ecosystem that comes with this. So the internet, electricity. You see, now we're running on generators. Now imagine, in fact, it's a good example. You are in the middle of your case and you're dialing in, and then power disappears. And often I have run cases off the Wi-Fi on my phone because I know whatever happens to the internet, and in Nairobi, Safaricom are here. It works pretty well on 5G. You can connect. Out here, we have Starlink and other options if you are out in the mashinani. But I think ultimately, to answer your last question, because I know there's the financial component to this. What happens, when we have these systems, sustainability, because we want to say we are introducing these tools to our surgeons. how do we keep them going? And COG comes into play. We were there to have these discussions because we were asking for Proximie and for SSK and for the hospitals, how does this partnership look like 5 years, 10 years down the line? And we are all committed to make sure this will continue. So this tool that we are now having in Kenya will continue to help our surgeons and our nurses and other clinicians who use it to embrace upskilling via telementoring and telepresence. So SSK is just one of the few. In Makueni, they have maternal and child health, very beautiful program. We'll get to hear about that. Dr. Ali where is Dr. Ali? Yeah, because he has his own story and he's a panelist, so we'll let him share that when he's up on stage.
Thank you. I see some more questions. And first of all, I think everybody's wondering what's going on. There's a main plenum, as you know, and His Excellency, the Prime Minister, Raila Odinga, is speaking and still speaking currently. So this is the only side event that's still going on during the main plenum. As soon as that finishes, everybody will come in and we'll start the whole program. But thank you very much too. We've got many excellencies in the front row currently being patient as well. Thank you for that. Okay, other questions. We've got, Kakamega County, right?
Sorry, I just wanted to, before the question. So the chain link has gone up. The fence is doing well. You see how that mesh is lying now straight, now nice and tight. What Dr. Omari is doing is in one to 5 areas, he's going to fix it so that you're fixing it and you can see what we call tackers. So we are seeing tackers there. They are fixing the mesh so that when the patient day 2, day 3 is moving, the mesh doesn't move with them as much. So usually you just need to fix it in 3 points and you find that it's okay. It's also very important to remember the structures that are down here because this tacker is like a pin. If you go and tack where the big mshipa is, where the big artery is, lots of bleeding. You don't want that. You remember where the nerves, he pointed out the nerves on this side. You don't want to tack there. If you tack there, the patient will remember your name for the rest of their lives. Because every time they move, they'll be in pain. But here's the thing. The risk of injuries to the nerves and the risk of injury to the vessels is much lower with minimal access surgery than with what we used to do Kitambo. Kitambo would have cut here and dissected the tissues away. We would have put that mesh in front. So when a patient coughs, it's pushed out and it becomes like a tent. But here the difference is it's now sandwiched between tissues. Even when someone coughs, it's like trying to push a fat person through a narrow door. They don't go through. And so that's what this technology now enables us to do.
So the reason why we went to here is because this surgery is going to be wrapping up in a moment, and then we'll have another one from the United Kingdom that's going to be coming online. But this is when Coast General is starting to wrap up. And so over to you.
Thank you. I just wanted to know, when you had answered my first question, you spoke about on-source revenue, and that is something that my county is struggling with. So I just wanted to know, is this particular technology covered by insurance for the patient? And also, what is the cost difference and how does partnerships with county governments look like? And then the last question, which level of hospitals does this work best in?
Ooh, wow. Okay, your microphone's actually better. Okay, so this technology works best pretty much anywhere, even in sub-county hospitals. As long as there's decent connectivity, you're good to go. So we've got very small environments, like Dr. Abdulaziz Ali has had to work in smaller ORs, and you're able to set it up really easy with off-the-shelf hardware, webcams. So you can be in a tiny place and it works, right? So that's great. Own source revenue, people have become creative. Moranga County's governor, what he did was he asked every citizen who wanted to partake in a digital health program. It's a package of digital health programs. They give a small nominal fee, like equivalent of $1 perhaps. But every single citizen who wants to participate and get access. And maybe they'll say, I want access to better surgical advice in my cases, etc. And then that annually allows him to then pay for the Starlink and coverage for all of his digital technologies. So this is where you get creative. Also, Moses, this is a really interesting thing that people can start to look at, like Aga Khan Hospital, right? There's bands that surgeons get paid for certain kinds of cases. Now, imagine if you, in your network of care, you can charge still as a surgeon, but at a smaller rate for consulting live for something. That's an idea that people have also had about implementing, but that's up to them and their health system as well. I think partnerships is important. We partner with Amazon AWS, who allows us to subsidize the cost of this. So you pay a really nominal fee. So we start off by installing it as a donation, and then the counties that are part of the Council of Governors program and the Surgical Society of Kenya's program, they get access. And then over a 2-year period, they start to own the technology at a subsidized rate. I think that's how we make it sustainable for everyone and have equity. I know you're like, don't forget me. Where you're from, please.
Hi, my name is Dr. Noel Orata. I am with Open Fences. These are my colleagues. Nice to see you all. I wanted to ask from maybe the Surgical Society of Kenya, this is amazing work. I'm wondering, will you be going into research, because you're gathering a lot of data that is actually stored? How are you going to maybe integrate that into COSEXA so that it makes sense? I also lecture for undergraduates. I'm wondering then, how can we use this to better education?
And the price. She wanted to know the price. Okay. First and foremost, before we go over to Dr. Michael Moachiro, Kenya Education Network, KENET, is now bringing Proximie into academic centers. And we've got Hillary Chesarek over there. So they've now installed Proximie into Meru, into Nakuru. They're going to go into Kilifi. And we're continuing to roll out for academic institutions. So they're going to start to layer that into teaching live. Can you imagine? Instead of having 100 residents crammed in trying to get a view, you can start to see it on the big screen and teach in the education program, which is really exciting. So now over to the research question, which is fantastic.
Yeah, thank you, Dr. Orata. Actually, there's a lot happening now. Just to point out, the surgery has ended up there. We'll be transitioning to the UK case. But to answer your question, we asked the same question. Now that we have the ability to track very many things. So in this one procedure, if you are watching keenly, so the surgeons were looking at technique. I can actually follow exposure, anatomy, blood loss. And then if you are teaching, we can break it down into steps and ask, how long did it take Stanley to move from being able to dissect this point to this point? And so we do have research already inbuilt. In fact, we are working with the guys here, Dr. Bita, and we will be setting up a nationwide prospective in real-time study to look at very many things. It has multiple components. We have laparoscopy, we have general surgery, we have endoscopy and minimally invasive. And then Modoka joined and asked many questions about neurosurgery. So all of these disciplines we can follow. Secondly, we will be at the universities. And one of the questions we are asking is, how do we use this tool to augment teaching? And I think you've had some good examples. So yes, we will be hopefully next year having some really good data to show on the research side on how we've been able to leverage Proximie for training and surgical education. Thank you very much. And karibu.
And can you imagine, I'll wrap this up, in cesarean section, safe maternal surgery, right? That started in Makowane County. But what you start to see is when you do paper-based review of clinical teams, they'll say, oh, we've reached 95.8% adherence to the surgical safety checklist by the WHO. But then when you look at the videos post-hoc, you see that it's 65.8%. There's a huge quality improvement gap that exists. So this is what it allows. Think about this in an ambulance. A lot of times you lose women in the ambulance from postpartum hemorrhage, and you don't know exactly why it happened. It's a black box. So we need to start having eyes in to be able to understand what actually is happening. Questions? Yep. Oh. They're starting? Okay.
Can hear me still? Can they still hear?
Even as the question comes, and I know Mwachiro is coming for this case, but I wanted you to reflect on something, and it's something Mudoka talked about.
Excellent.
Imagine you are a cook.
Fine.
You think you're the best cook in the world. But imagine you put a camera in your kitchen, and this camera records you every time you cook. The opportunity it gives you is the opportunity to go back and look at your video of yourself cooking and say, I wonder if I could cook more efficiently if I put my spices, rather than up there, I put them here. If I cut all my veggies before, not after. And that's why for every theater where we have installed Proximie, the culture change we are pushing for is get into the habit of recording all your cases. Because then it stops just being about chakula changu kinatoka aje, how does my food taste? You start looking at the process of preparing your food. So you look at the room view and you're always saying, how is my team
Your Excellency is that
in the OR? How are my supplies? How many times does my tech have to run out of the room to bring supplies? And you start looking at how to increase efficiencies.
and
Are we ready to go in, or we take more questions?
see that's usually the biggest issue.
Okay, the surgeon is being mic'd up. Shannon, we can get questions.
Thank you. So we're dialing in live right now to the United Kingdom and BHRUT, which is part of the National Health Service, NHS, in London. So we're going to go live in a moment with Dr. Marchiro. And we're also having Uganda dial in simultaneously. So we'll have Uganda, Kenya, and London dialed in together. Question over here in the meantime. You are sitting so far away. We need Proximie for you.
Thank you. My name's Ezra Kirui from Bomet. Mine is just a comment or not really a question. In Bomet, we have a Longisa County Referral Hospital. And I want to affirm that we have adopted this, the teledoc machine utilizing the telemedicine. So we are also open for a partnership with you. As we are going to launch the Mother and Child Wellness Center, that 200-bed capacity. And I'm sure we are going to need partnership in training and research.
We just
That's
finished
all.
hernia. The patient had a hernia.
Do we have somebody over here? Yes.
Laparoscopically from inside,
This is actually louder.
dissected it and repaired.
Mine is actually like a culture
Generally
question,
open, it would
and I'm curious
but laparoscopically you
at the average age of the surgeons who are using this system.
working today. Sorry? Well, it depends on the complexity of the case, but this one would have taken us 30 to 40 minutes to finish.
So we're going to give it to the seasoned surgeon over here. Tell us where you serve, what your role is.
Same day.
Okay. My name is Dr. Caesar Bita. I think I've been given because I think I'm the oldest in the room. But just to tell you that I'm not yet 50, yet I'm considered an old surgeon. So the average age of the surgeons who are using this is mainly in their 40s and late 30s. The reason because Kenya took time to adopt it. Okay. So you find that most of the people who are using it are in their 40s. Yeah? I have one of my mentees in the room, Dr. Dare, you can wave for them. She's, you're 37 or somewhere near there. So
Thank you so much.
it's a technology that is being embraced and growing. But if you look at it, I'm the vice president of the Surgical Society of Kenya at 49. Where's the president? He's 47. So the average age of your surgeon in Kenya is relatively young. Okay? And generally, they're embracing the technology. Yeah. So we are the guys you're going to meet. If you come to Kisumu, I'm the surgeon here. Dr. Dare is the surgeon there. So you're the guys who are serving you both in public and private. So don't be worried about our age. Thank you.
I also find it really funny that Kenyan surgeons never say what their age is. They always want to do a bracket, like I'm between 20 and 50. And they want you to know by how they dress and the white hair they have. I don't know. Did that answer the question okay? Any other questions in the meantime from the audience?
Facilitate.
How many of you in your counties or in your organizations are utilizing technology? It doesn't have to be Proximie, but just technology as a whole. How do you feel about digital literacy in your environments? Or are you from a tech startup?
Today, London case.
No. Oh.
Yeah, thank you. My name is Washington Dinga. From a medtech startup. It's called Neopenda. So Neopenda, we actually use technology in the space of patients monitoring. We have a couple of counties that we work with, including Kisii and Makueni. And I think as most of us will agree, the adoption part of it is what sometimes is a challenge. And when the question about the age, the average age came about, I think it was timely because we see even in our implementation that the younger generation are faster to adopt the upcoming technologies as compared to the older generation. And I think that's something that we need. It's a culture that has been there systemically. And I think it's something that it's work in progress. And we may use the champions that are there as the younger generation to also, if it can happen, to influence the uptake within those other generations. Because one thing that we are alive to is, especially like in the surgical society, you find the older generations are also more experienced, they are mentors. And so if they can adopt such technologies, then it speaks a lot to the younger generation, and scaling up becomes much, much more easier. I think the other thing that we have seen in deploying technology that's working is also just to be able to speak to the user workflows and how the technology is able to enable their current workflow to be much more efficient and effective. I think that's a great part of it, because if they see it as an enabler of what they are doing, then they become more receptive and they can be able to easily adopt it. I thank you for that, and I think we can continue.
Mr. Dinga, thank you so much. And Neopenda is something that is really needed in order to be able to decentralize the way that we monitor neonates. And that's incredible what you're able to do with such little technology and bands that you have on the babies. I want to say something? Dr. Mwatha.
Thank you so much, Shannon, for that question. I think for us as Makueni, we are happy to have been the very first county to embrace Proximie technology in the country and also in Africa. And for the very first time, we can brag to Dr. Nje here that the public facilities were teaching the private facilities on how to do things using technology. So we were happy as a government institution to onboard private facilities to learn our learning lessons. I think one of the big challenges and the good things that we have learned through the process, that embracing technology to make it more efficient and effective in what you're doing, and also giving you an opportunity to audit yourself makes a big difference, and also to do a lot of peer-to-peer learning. So technology embracement is one of those things as a county we have really embraced. So even for the young investors who want to embrace and test their technology, they're welcome to Makueni County. Thank you.
Thank you, Dr. Mwatha. We are happy that we... So this is good bi-directional learning, and thank you very much. We've enjoyed being hosted by you in Makueni. Now, we should also invite us more often. And all of the counties here, please, this is part of the whole idea of having nationwide linkages that we can learn from each other. And in that spirit, I want us to now transition. So we've just shown you national in Kenya, within Kenya linkages. We are now going to switch and show you, this is international UK to Kenya connection. So I'm going to keep looking at you so that you can see, because they are seeing what I'm seeing right now. So you can wave and say hi to the UK team. Hi. So we have Prof. Nero on the other side. They're very busy, actually. They might not, most surgeons try to keep their eye on the field. But whoever is in the room with them can see this on the screen. And so Prof. Nero is doing a surgery right now on the abdomen. And we've found them somewhere in there. I think they were dissecting and freeing up momentum and things. Yes?
I just wanted to give the floor quickly to Dr. Paul Musilla, who is from Macoini County. He is now the CECM for Land and Environment. Very recently was Health, and my favorite person other than Dr. Moatha in Macoini County. No, you're like on a different level.
Thank you, Shannon. Your Excellencies. Sorry, I have to request that I make a brief comment because I might be leaving before the session is over. Yes, my name is Paul Musila, Dr. Paul Musila. I have served Waziri for Health in Makueni County and now I transitioned in the last 1 week or so to Lands Environment. So the technology, I just wanted to say something about it before we start formally. It's not just for surgeons. It's actually not for doctors only. Everyone who is interested in quality in the space of healthcare, if you're an administrator, you need to ensure that we can have this kind of, eyes in our theaters. Dr. Mother has mentioned about the audit. We started off, and I think it will come a little bit more clearer. We started off in the obstetric safe surgery space, where we wanted to be sure we know what is happening in our theaters, because our concern at that time was maternal mortality. So that's how we started off in Makueni County. And there's a checklist. So the first thing you're going to do as you do the audits, especially if there's a maternal mortality or there's a near miss, then you will go back to the recordings and sit down as you do your audit and go through it. Was everything done as it was supposed to be done? That brought a bit of anxiety. It's a big brother, kind of scenario. So even the staff will actually resist it. I have to warn you that they will be anxious about it. They don't want to be, molliquad, if I may use that word. So they require a lot of sensitization for the staff. And that is one of the interactions that we have had with the Proximie Technology, Shannon, and the Surgical Society of Kenya. 4 weeks ago, we had to call theater users from the 5 hospitals in the county that have the technology. 5 hospitals, 7 theaters. And we put them in a hall and we told them, don't worry. We are not really using this for the purposes of the kiboko, for the purposes of the cane. We want to improve on quality. We want to know how we can improve on the service provision in our county. Bottom line, we want our patients to be safe. So let's think about it, everybody. What happened when we saw how beneficial it is? I said we cannot keep quiet about it. And we quickly had a discussion with Director Katra at the COG. And we were able now to have a sitting. Myself, Shannon, Director Katra, His Excellency the Governor, Mutula Kilonzo Jr. And we actually discussed it in Delta House. And that's how now our colleagues in SSK came in. It is also already installed in Chiromo. Noel, it's already in Chiromo campus for teaching purposes. So even the senior colleagues, Professor Ogengo and the others that you know. So the edge factor is not really limiting, not too limiting. We were with them and we actually installed it in Chiromo campus where we all trained many decades ago. Thank you and God bless you.
Thank you very much, sir. And Macoini County, we'll talk about this when the real program begins and after Prime Minister is finished with the speech and everybody comes over. Macoini County was the first on the African continent to have Proximie. And I think that's something to really talk about because now Ethiopia and Rwanda are competing with Kenya and Tanzania. And I love seeing that. Because like I said before, when they see me walk in with my Kenyan bracelet and they go, why are you bringing that into our country? I said, because they were the first. Any other questions? We're going to start with the surgery now from BHRUT. Please go ahead.
Yeah, so we're going to switch over to the UK team. Prof. Niro, go ahead.
Hi there. Hi, everyone.
Hi. Please wave. Hi. Yeah, thank you. So, Prof, go ahead. We can hear you.
Hi, fantastic. So I'm with my colleague, Ahmed Barkova, who's doing this laparoscopic right hemicolectomy. I'm just going to introduce him in a second. I think you've got the video feed from our lap stack, hopefully.
Yes, it's crisp, very crisp.
Very good, fantastic. And then after hopefully a little bit of time here, there'll be a stream from the feed next door in theatre 9, where we've got a complex rectal case.
Okay.
Which I know more about the details of that one, but in a moment, when Armand's free, I'll just give him the headset so he can tell you a little bit about this one.
Okay. Do you mind telling us a little bit about the patient that you are operating on and what the aim of this surgery is about?
So the second surgery that you'll be fed into is a lady in her 60s.
Okay.
She's had a low rectal cancer that at the time of diagnosis, it was quite advanced. It was T4B, N2B, M0, so no metastatic disease. At the time of presenting, she was very symptomatic, and at MDT, we deemed that she would need some long-course chemoradiation. So she had to have a stoma first, but because she was already partially obstructed and a poor nutritional state, I believe she had some stoma retraction and possibly a bit of wound dehiscence that delayed her slightly. But she had the stoma, had that surgery, then went through chemo-rad. She didn't have a complete response, but she had a fairly good response. So we give that a tumor regression grade score of 3 out of 5.
Okay.
So it did shrink the tumor, but it didn't get rid of it completely. So she's here today for surgery with a view of hopefully curative intent. But the plan will be that we take down her colostomy, remove the tumor, join her. Hopefully, I think it's at the point where it's reconstructible. She's had a hysterectomy previously, but we have been told that on early imaging, it may involve the posterior vagina, and it may involve, I believe it was a left ovary. There's a slight degree of a hydroureter as well, and we don't know whether that might be from some peritoneal disease that wasn't picked up on the scan. So joining me, apart from myself and Mr. Cool, who's another colorectal surgeon that does eccentrative and hypec work, we've also got 2 other surgeons, one of the urology consultants, Sandy Goodrell, in case we need to do anything in terms of ureteric reconstruction. And also, we've got Reka Winterkal, who's a gynae oncologist, in case we need to do anything with a gynae apparatus. So we've sort of got all hands on deck in case we need to do more.
Okay. So now I'm going to ambush the Deputy High Commissioner to the UK, who's sitting right here. She's going to say a few words just because we have her here. Go ahead.
I don't know if you can hear me. He looks kind of,
I can hear you clearly.
I'm going to give her the microphone.
Okay. Right. Okay. Hello, this is Lee Stubblefield. I'm the Deputy British High Commissioner here in Kenya. We are sitting, I think you can see, we're sitting in a large, quite warm hall watching you guys work.
Hi, welcome. I'm really sorry I can see you, but I can't hear you at the moment.
Probably not such a great idea.
No, the audio is not coming through.
You go back to your mic. Just say we're very impressed.
Rob, can you hear me?
I think.
Yeah. Can you hear me, Prof?
I can hear you. Yeah.
Okay, so I think I'm actually on the PX headset. That's why
I can't hear you very well now.
Yes. Sorry. So she says hi, and says you're doing very well, and doesn't want to distract you. But thank you all for the work that you're doing.
It might be positional, but the at the moment. I could hear you about a minute ago.
Okay. So I have a question for you. Can you hear me now? Okay. Technology is being
just about hear you.
Okay. Give us a minute.
That's better. I can hear you now.
Okay. So I have a question for you. Given the setup in the UK in terms of connectivity, because many of the questions we had just now were about how does this work?
Yes, that's better. I can hear that.
Excellent. In different settings. What is your comment on your setup and how you make Proximie and this kind of connectivity work when you're trying to teach?
I think someone was sound checking with 1, 2, and I could hear that clearly, but the other audio is a bit on and off.
Prof, can you hear me?
If you're sorting, I can also.
Okay, so I'm going to try this one more time. Prof, can you hear me now?
Yes, that's better. I can hear you now. Sorry.
Yeah, my fault. I switched all these things on my head, and then we lost a good connection. So I'll repeat the question. If you look at the setup in the UK in terms of connectivity.
Sorry, I've lost you again.
Oh. Okay, as we sort it out, we'll do a small activity.
Story come. The story of intestines. I get excited about showing people intestines.
Not very well. I can hear something.
So a bit of orientation. Patient's head is behind the curtain, so the patient's feet are toward us. The camera comes here where the navel is, and then they operate on either side. And so that you can see where the light is pointing, and so the light comes down there. What they're operating on is the right colon, what is called the ascending colon. So you eat food, comes down your food pipe, stomach, comes to the small intestine, which is in the middle. Then the large intestine comes like a box on the right, up, down, then comes down into an S to the rectum. So when we're removing the right side of the colon, we lift it up. And that's why they keep lifting it up, because the mishipa, the blood vessels, come to it from the middle and hold it like it's going into an apron. Imagine if I had tubes going there, but now I need to release these tubes here so that I can remove the intestine. That's what they're working towards. Now, that means you have to release it down here from where the small intestine comes to join the large, because the large intestine on the right and the left sits behind another curtain. In anatomy, we call they're sitting behind the peritoneum. So you have to release it from behind that curtain so that you can remove it, remove the section that has the tumor, the cancer, and then join it back together. That's what, on his right hand, is what we call advanced energy. Now, before, if you needed to cut where there are blood vessels, you'd need to tie. So it was very cumbersome. You'd need to put in some thread, tie them shipper, put in, tie them shipper. What happens now is you have targeted energy in scissors. And so you go in with these shears. In this case, the advanced energy is actually ultrasound. So between those two jaws of that scissor, the blade, one of the blades vibrates very fast. And that allows you, as it's cutting, it actually seals the blood vessels, the mshipa. In fact, that setting that you can see there, 3 and 5. If I go with 3, it vibrates very slowly and allows the blood vessel to kushikana, to coagulate and seal, and so that it doesn't bleed. If I press the button that activates 5, it vibrates very fast and cuts before it seals. So sometimes you can do that to cut tissues that don't have blood vessels. But if you do that with a tissue that has a blood vessel, then you're likely to bleed. Because it's the right side, the liver is also on this side. And so you can see the patient's liver and you can see their gallbladder down there. As surgeons, we can tell what you eat based on this liver margin. Okay? You can come and say, but Daktari, I have a 6-pack. I jog every day. If this margin is rounded in this case, then you're having the early signs of what you call fatty liver. And then you come to us as wellness coaches and we tell you what to eat so that you can be lean and mean. But usually for those who don't have a fatty liver, that liver margin is like a wave. It's very thin, it's very sharp, and goes like a wave. So in patients who do not have cancer, you find that these tissues are very easy to dissect. Very easy to dissect. In this case, what you are seeing is tissues that are all stuck together, because what happens when you have cancer in your body, the cancer loves blood. Blood is its food. So it stimulates your body. It says, give me more blood, give me more blood. And so you have blood vessels coming where they shouldn't be. And a lot of the time you'll also find it contributes to that. You see how this tissue here is stuck to the anterior wall? That's what the surgeons are trying to tweak. Have we gotten the audio back with Prof. Niru? Machiro, audio is back with Prof. Niru? Great. Story? Yes, today you will learn about intestine. When you live here, at least go home and tell people, you know, I was told about the large intestines, the small intestines. Then you didn't waste per diem. Machiro, back to you.
And to pin that on, it's very useful to then go and see how things work in different places, and you can bring the benefits of some of that experience into our own trust, where things could obviously be done differently or work more efficiently. So I think at the moment we've got very big backlogs of elective work, and especially since COVID, there's a big push to try and perform high volume, low complexity work. And get through big lists as quickly as possible, but safely as possible. And I think looking at how people operate is one thing, but it's looking at the whole team and looking at how theatre efficiencies can help improve things for marginal gains. So I think that whilst we're beginning to do high volume, low complexity lists here for things like gallbladders and hernias, obviously for cancer surgery, that's different, and it's a different level of timeframes and complexities. So I think at the moment, hopefully you've got a nice view of Mr. Bhargava taking down the hepatic flexure before delivering that specimen. And I suspect he'll do a staple side-to-side anastomosis outside of the abdomen. We're beginning to do other things. We're beginning to do robotic surgery as well. Laparoscopic surgery is obviously very big, but for the very large complex cancers, we still do open surgery. So what we'll be doing next door in Theatre 8 will be an open case. So I think all exposures to all modalities is very important. But I think also the benefits are there for healthcare systems and how we can improve both in terms of our efficiency, help other people's efficiency, if it's a learning curve that we've been through already, but also just increasing the clinical exposure for our team and for our trainees, and just to have and just increasing clinical networks. Really, it's always lovely to have new friends in new places and to be able to come out and potentially build collaborations, which may even involve coming out and operating and hopefully finding each other face to face as well in the future.
Yeah, thank you, Prof. So we got back online when you were explaining. I mean, he was answering the question I'd asked about connectivity and how this works in the UK. what setups do they use it for. And so they are in the middle of this procedure, probably will be there for some time, because as you had, this patient had treatment and has a recurrence of disease, and now they're trying to give this patient a curative resection and to get everything out. And so I think, Prof, any other comments you'd like to make towards utility of this for teleproctoring?
I'm very sorry. I can't hear you at the moment very clearly.
Let me go closer to the. I think that we figured out what the problem is. It's the radius I've been using. Any comments on?
That's lovely. I can hear you now.
You can hear me? Yes. Fantastic. So we've been talking about research and teleproctoring. Is there any discussions along those lines in the UK?
Yes, it's definitely something that's been discussed a lot, especially around robotic surgery, because we went through a big phase of proctoring for that recently. And we had to give our proctors lots of notice so they could cancel their clinical commitments and travel often large distances. I think teleproctoring is something that would definitely be a benefit, and we're starting to use, not potentially for the very first few cases, but once people have a little bit of autonomy and a little bit of experience with using new equipment, then I think it's more about fine-tuning and finessing, and a lot of that can be done with teleproctoring. So certainly we've looked at options like importing people's expertise from other countries like America and Australia for where they've potentially been further ahead in terms of, for example, robotic surgical learning curves, and then being able to access support where they may be more specialized and be further along in the learning curve. And I think that's something that would be very keen to take on. I think that will be something that becomes really facilitated with systems like Proximie.
Mm-hmm. Yeah, and then one final question. If you look at what you are doing in the UK and what we are doing here in Kenya, because just before we were watching Coast General demonstrate a hernia surgery. What opportunities do you think you would personally look towards supporting the Kenyan ecosystem in surgery and similar discussions?
So I think we'd be looking to see what there is currently. I think there's always opportunities to learn as a two-way thing in terms of, there'll be differences in equipment, there may be differences in resources, and there may be differences in pressures. So it'll be interesting to see how people learn from those. But also I think in terms of mentoring, if laparoscopy is something that is sort of coming along in terms of learning curve, and if there are people that have experience in that and in training. So for example, Mr. Bhargava here does a lot of training for laparoscopy in a big laparoscopic centre nearby in Colchester called the Iceni Centre. So those sorts of opportunities exist, and myself and other colleagues, Richard Bolton, do both robotic training at Imperial and a few other hospitals. So that ability to link us with this sort of technology gives us a really good view of what's happening inside and outside the theatre, gives us the ability to interact in terms of audio, make changes, potentially even draw on the screen and say that we might do something slightly differently, and we could make suggestions and proposals, and obviously that works in both directions. So I think that there's the potential to do a lot with tele-mentoring and tele-proctoring in the future. I think this will make things a lot easier.
Yeah, thank you, Prof.
It does away with a lot of, reduces the amount of paperwork too, because I think to bring clinicians across from one system to another, often there's quite a lot of paperwork to get through. And I think if it's sort of a tele-mentoring or tele-proctoring, it probably makes things a lot easier. We're just demonstrating a few of the abilities to to draw on the system.
So I'm going to bring in Dr. Joseph Damoy, who is joining us live from Uganda. So Joseph is a general surgeon. He works in a hospital.
Hi, Dr. Joseph.
Thank you, Prof. Joseph, we can see you. Can you say hi and introduce yourself?
Sorry, I think since connecting, the audio's started glitching again.
Okay. We'll give him a few moments till we can hear him.
No problem.
Yeah, because I can't hear him on my headset as well. But for the audience, Joseph is based in a hospital in Jinja. It's Chabiria Surgical Center. He runs surgery there, does the laparoscopy, endoscopy procedures. And one of the things that we have been able to do is to connect in real time between Joseph in Uganda, surgeon in Malawi, Ethiopia, and really demonstrate what real-time communities of practice are. We were hoping that he could say a few words about what he does. But as he does so, I think we can get some questions from the audience. Any questions so far up to this point? Or any comments, actually? Maybe not questions, but comments. I know we had a few people who joined. Any comments or questions? You've been able to see the Kenyan system, the UK system, and we were hoping Joseph could show us the East Africa system. Questions or comments?
Check. Check. 1, 2.
What does a teacher do when the students don't ask questions? He asks questions.
1, 2.
What did we say that gauze is for? What did we say the gauze is for? We've seen that thing that looks like a handkerchief inside. What did we say it's for?
I think it will drain some blood. It will also try to kubembeleza the tissue around so that it's...
Radi! He's gotten it, yes? Wonderful, wonderful. Now, at 12 o'clock, what do we call that structure at 12 o'clock? Point for me the structure at 12 o'clock. It's now at around 1 o'clock. What do we call that structure at 1 o'clock? We have a response here.
Thank you. My name is Joe Kioko from Makueni County. I think you mentioned that was the gallbladder.
Hapo sawa, Radi! Gallbladder. Niwaambia pa diem is considered. Joseph is back? Joseph is back. Let's have a listen to Joseph.
Say that.
I had to look at on Joseph clearly, and it's gone completely mute now. I can't do anything.
Yes, Dr. Mike. All right. Dr. Joseph Damoy from Uganda, Chabira Surgical Center. I've been a good beneficiary of tele collaborations like what we have today. But Dr. Mike, I didn't hear the initial parts of your introduction, so if you can just go back there again.
Yeah, Joseph is a proper surgeon, saying I should all protocol observe, repeat everything I said. So, Joseph, I said you are based in Chabiria, in Jinja, and you are an excellent surgeon. And we were looking forward to hear what you had to share about your experience with using Proximie.
We haven't got audio on this side. I'm not sure if you can hear us okay?
Yes, we can.
Yes, I can hear you. Yeah, Dr. Mike, I think I'll take out my video. Maybe my feed will be better. Right. So yes, I have realized collaborations like this quite a bit already, especially in the areas of endoscopy and laparoscopy. In our initial work with endoscopy, I had an on-site visit by an experienced gastroenterologist who introduced us to the basics of endoscopy. That was only a 1 week on-site interaction, but we realized that endoscopy is not just holding the scope and getting it in, but knowing what you see is the bigger part of it. That is how we tapped into the first experience of this gastroenterologist from New York. Of experience. So every time we had a procedure, we would invite him remotely. He has a direct view of the feed from our endoscopy tower, but also he has a view of the hands of the operator, so that he would give instructions, move your dial up, move to the left, apply torque to the left or to the right. This definitely was very helpful in our initial stages in the endoscopy practice. I remember initially colonoscopy, which was more difficult. We would take a long time, but at the end of it all, I could almost say purely we developed our endoscopy practice remotely or based on remote support. Recently, I visited Dr. Machiro in Kenya to observe him perform ERCP. I can't wait to employ connection with Proximie now, which has put all the pieces of you need for remote collaboration together. I can't wait to have Dr. Mike, use the same method to support us as we develop our ERCP practice from the initial stages. But of course, utilize the same in laparoscopy. When it made a lot of sense to invite with more years of practice, to just log into your case. Simple advice like, I would retract my infundibulum to the left of the patient and to the right of the patient. This will give me a better angle for dissecting around the cystic duct and the cystic artery, when you add more retraction to the fundus of the gallbladder, retract more with your left hand, that will give you a better dissection. So simple advice like this eventually led us through developing our laparoscopy practice a lot. I was probably performing my 5th case. Imagine working with someone who has done hundreds of cases. It's more like having them live in your operating room. So this has been my experience with telecollaborations like this. And now with Proximie,
So Joseph, maybe to ask you, what are the challenges that you're facing in Uganda in terms of connectivity to allow this kind of systems to work? Any comments on challenges you've had to overcome towards connectivity?
Yes, Dr. Mike, I think the one very common challenge is internet, especially bandwidth. Initially, we thought having internet alone is adequate, but recently we realized that you need a particular bandwidth to be able to have a stable transmission and a seamless interaction during a live procedure. So I think the bandwidth has been a bigger issue. Of course, a smaller one is teaching the whole team around be familiar with whatever connectivity system you use, but that is a smaller one, though important. If the more people you have around you who are familiar with the connectivity and you know how to connect this to the other, the better, because at some point in the procedure, as the surgeon, you're busy, so you need more people around you. Those are the two challenges I could put forward.
So Joseph, final comments from you, and then we will switch back to Prof. And that is, in your opinion, in your opinion, what do you think? You think, in your personal opinion, would be the best use of this in terms of education, research, and mentorship in Uganda?
So I have realized in our various hospitals and stages in our surgical practice, every often involving people with different experience or a different level of comfort with a particular procedure makes a big difference. My biggest take is we should scale this up so much to simply be put as interconnect many operating theaters. Recently, we had a number of trainees in the basics of laparoscopic surgery here at our hospital, the Chabira Surgical Center. But the question they have at the end of the training is, how can you support me when I'm back at my hospital? And I think having interconnectivity through systems like Proximie will be a best way of supporting people at their initial stages of practice. But also, you mentioned research. The different setups have a lot that can be learned by one setup. For example, today I attended the TAP hernia repair from Coast Hospital. In my own setting, I use a dual tape. So now I begin to see that I can actually also adapt TAP with its advantages or differences from tape. So that means I'll be able to learn from different practices. And now that I attend this case from the UK, hopefully by the end I've also looked at, I could actually do this. A simple thing, I saw the person who was doing section from inside the abdomen was so careful. His pressure inside the abdomen wasn't going down, and I realized the use of the left hand was very helpful to press the tissues down and then have the suction submerged. So yes, I think there will be a lot that one theater can learn from the other theater.
Joseph, we are going to switch back to Prof because I see they are putting in the port to do some extraction. So Prof, if you can hear me, Prof, can you hear me? Hello, Prof, can you hear me? He's on mute. We can... Prof, you can hear me. You need to unmute on your side.
Can you hear me?
Yes, we can hear you. So you can walk us through where you've reached. Yes, thank you.
Thank you. So the bowel tumor has been mobilized, and now we're just extracting through an Alexis. It's a nice port that just gives good retraction.
Okay, so
hope you've got a good view.
Yeah, for the non-surgeons in the room, they are done with the cutting this piece of tissue out, and now usually you have to make an opening that is big enough to get it out. So they started with a tiny hole, and then they expanded it, and now they're going to work their way to bring it out into the field of view. Yeah, Prof, go ahead.
So yes, it's just slightly bigger than the size of the tumor.
Okay.
And we're just extracting the colon now. So you should get a nice view of all the mobilization.
Yeah, we have a very good view.
Affected.
Prof, on average, how many of these cases do you do say per month or per year? How often do you get to do this kind of procedures?
So a year, for bowel cancer specifically, roughly around 50. If you include other things like inflammatory bowel disease and emergency work, probably closer to about 75, 80. I think as a unit, we do about 250 cancer resections per year. But then we do quite a mix. So we do early rectal cancers, we do laparoscopic cases, we do open cases for pelvic exenteration, and where we give intraoperative chemotherapy for peritoneal disease. And we also do straightforward cancer resections now, more and more with robotic surgery as well.
Mm-hmm. Then the follow-up question is, so here in Kenya, we have a slightly different setup, as you know. So in the NHS, by the time you see these patients, what's the referral pathway look like?
So we tend to get these patients referred on a 2-week wait referral pathway from the GPs, from primary care. And if they have any red flag symptoms for any sort of tumor, they get referred on this pathway. So then they see us usually within 2 weeks, and their investigations have to be completed within 2 weeks. We need to be able to notify the patient of whether they have a cancer diagnosis or not within 28 days from receiving a referral. So generally, we try and get all our investigations done and the results back. And obviously, for the majority, that's informing them that they haven't got cancer. But within colorectal surgery, it generally tends to be about 3% the pickup rate. And then if they do have cancer, we plan to treat them usually within 62 days from the time of referral, or roughly 31 days from the time that we've given them the diagnosis and the plan of what the treatment will be. So that may obviously be, if it's a rectal cancer, neoadjuvant therapy, or it may be straight to surgery. But if it's colonic cancer, more often straight to surgery. It can be a challenge trying to beat those breach times, but that's generally the aim. And for the most part, we're a fairly big unit. We have about 9 colorectal surgeons. So for the most part, we usually manage to do that. But obviously, cancer doesn't choose when it comes. So we have busy months and some months which are less busy. But most of the time, there's enough to keep everyone busy.
Mm-hmm. You have a question from the audience, actually 3 questions now. So I'm going to lump them all into one. And the questions are, what is the cost of this kind of surgery? What is the follow-up look like? And for your hospital, how do you deal with the subsequent care of the patient? So cost, follow-up, and care of the patient afterwards.
Okay, so generally as patients, everyone's very well shielded from the numbers because they don't have to pay for anything. It's provided, well, they pay, but it's slightly hidden. So we pay it through our taxes, I guess. But in terms of, it's all covered and available through the NHS. So seeing the GP in primary care, they wouldn't pay for that. Seeing us, again, they wouldn't pay for, nor for their tests, investigations, and nor for their treatment. So at point of care, it's effectively free. In terms of the actual cost to the hospital, it does depend on the type of surgery. So actually open surgery is, if you just look at the episode in theatre, cheaper than laparoscopic or robotic surgery. But if you count the overall episode, including the number of days a patient stays in hospital, blood loss, post-op, opiate requirement, and when you take all of these things into account, I think through the learning curve, historically, laparoscopy was more expensive, but is now considered cheaper. And I believe that will eventually happen with robotic surgery as well, though we're not at that point yet. In terms of aftercare, we tend to have all patients on a surveillance program. So they will see us post-operatively with the results from the histology. And then depending on whether the follow-up care is determined to be adjuvant chemotherapy in which case they would go and see the oncology team initially. Then either after they've had their adjuvant chemotherapy or if they're deemed to be for surgical follow-up, we have specialized cancer nurses, and they follow a protocol for looking after these patients, and we follow them up for 5 years. I think historically it may have been 10, but at least as in the last 10, 15 years, we do 5 years of follow-up. And that's a combination of blood tests, CEA, and colonoscopies, CT scans, which are on a schedule. But if a patient has symptoms at any point whilst on that journey, then of course we bring these tests forward. We want to try and pick up anything like any sort of recurrence as early as possible whilst it's still treatable. And essentially the CNS nurses are a huge support. So with a hospital with this sort of volume, the 5-year support network would probably be for about 1,500 to 2,000 patients.
Yeah, thank you. And I think you've brought a good point out about the role of teams and having, the nurses and the other parts who fit into this ecosystem. There was a comment in the audience about the gadget you have used. I'll use the exact words. What was that gadget? The stapler that was used to make the resection just now.
That was, yes. So that's TLC 75. It's one of the staplers that we use frequently here, both in open and laparoscopic surgery. And it fires two double lines of staples, and then fires a blade down the middle, so it staples both ends of the bowel and then divides in between. We can use that for transecting, but we can also use it for doing side-to-side anastomosis.
Yeah, thank you. And so we are preparing to officially now start this session. So Prof, thank you for the feedback and the good discussion that we've been having. We will have your feed playing in the background, but we will be transitioning to formally start this session. So really thank you for all the comments you've made and for allowing us to take part in this case virtually. And we are grateful to your team for the work that you do in the UK to help patients and to advance patient care. And so really, thank you very much. But we will be transitioning to the main session now. Joseph, thank you as well for joining us.
Thank you.
Yeah, so any final comments, Prof, as we finish?
Thank you. Thanks for the opportunity, especially to everyone and Proximie and Michael and for inviting us. And I think hopefully we'll have the opportunity to do much more of this in the future. Many thanks again.
Thank you, Prof. And so I will, Joseph, any final comments before I hand over this? Yeah, we're going to keep you in the background, so don't go away, just that we are transitioning to the main session. So Joseph, thank you for staying online.
Maybe you can give 5 minutes to just see what is going on. Just explain to the governor what is going on.
Okay. So Prof, I'm going to change that a little bit because we've just been joined by the governor. Karibu sana. It's a pleasure to have you here. And we want to welcome you to this session. And we will allow the UK team to explain what you are doing. Karibu sana. I'm fine, thank you. And welcome. Yes, so Prof, we just probably you can do a executive summary. Yeah, a quick one, maybe 2 minutes of what you've been doing, just because everyone is now here and we'd like to formally start. So Prof, you can hear me? Or he may not have his headset on because I can see he doesn't have his. Okay, so I can describe what we are seeing because I see Prof doesn't have his headset on. So essentially, this surgery was for a lady who had a lesion in her abdomen and had gone for chemotherapy, radiotherapy, first line, but then the problem came back again, and so was brought in for a second surgery. And the goal of this procedure is to try and get everything out and essentially give this patient a curative procedure. And so for the last hour or so, they've been slowly taking us through. They opened into the abdomen, laparoscopic showed us the views, identified where the problem is. And just before you walked in, they had just mobilized that segment and removed it. And that's the little plastic thing that was on the screen. And so now this case is multidisciplinary because it involves a general surgeon. They also had a obstetric gynecology consultant, and they also had a urologist because there was an area of the pipes that flow down from the kidney to the bladder that was seemingly blocked, that they were thinking they might have to do some reconstruction at the end of this procedure. So you've come right at they're now getting towards the tail end. And yeah, exactly. And just before this, we had a live surgery from right here in Kenya in Coast General. And Dr. Omar Ramadan was doing hernia surgery on a patient. And so he did reconstruction, placed a mesh, which we saw live. And they finished a bit back. So we had crossed over to see what was going on in the UK. I think that's about sums it. And I'll hand over the microphone to Shannon.
Much. Thank you so much, everybody. And we'll keep BHRUT out of the NHS in London up on the screen here with the team quietly in the background. And we've been very privileged to see 2 surgeries today, one here in Kenya in Mombasa, as Dr. Michael Mwachira just mentioned, as well as in London, and to communicate across 3 different countries. We had Uganda, we had Kenya, and we had London all talking together at the same time. And this is something in Tharaka Nithi, in Makueni, in Wajir, in Garissa, 28 hubs in 13 counties now, thanks to the Council of Governors, Health Committee, and the Surgical Society of Kenya. So welcome, everybody. Please come on in. Please do come on in. We're starting the session now. Take a seat. So I am Shannon Shibata Germanos. I'm the head of global health at Proximie. And I'm really delighted to invite you here today. We are hosting this session today for you. So Your Excellencies, distinguished guests, colleagues, friends, it's my great honor to welcome you to this session. And first, I have to thank Director Katra Ali and her incredible team at the Health Services Committee, including Dr. Simon, Paris, Charity, and Jemima. You are people who keep all of this running behind the scenes, and you work tirelessly day and night. We recognize you for all of the work to make this happen. When I look around this room, I see what truly matters. It's you, because each person in this room is precious. Today, we're putting surgery front and center, and the surgeons and teams here in the front row. This is why we do what we do. In a moment, you will hear about digital surgery and why it matters. But here's the truth. One day, each of us, or someone we desperately love, will need surgery. In that most vulnerable moment, it will be these people in the front row right here who are going to be meeting you in your most vulnerable moment, giving you the care that you need, and fighting for your life. Our mission is to ensure that they are fully equipped to serve you when you need it the most. Kenya's flag carries the word I love most, and you're all going to roll your eyes because it's got a political connotation to it, I know, but just go with me for a second. Harambee. Pulling together. For me as an outsider, it means everything. From Makueni to Garissa, Homa Bay to Kisumu, I've seen surgeons serve late into the night. Dr. Muthoka, when you arrived here, you had just spent 8 hours in a neurosurgery in Makueni County. You came with your eyes bloodshot to the airport. You served your citizens well. You are the reason we do what we do. Yeah, please clap. They deserve it because most of the time they're not seen, they're not heard. They just do what they do because they love the citizens and they love surgery. So they are the best of humankind. So this session is not about us talking at you. As you've seen earlier, it's about you talking with us. It's about all of us pulling together. And as John F. Kennedy once said, we all know this very well, ask not what your country can do for you, ask what you can do for your country. Your surgeons, your clinicians, and innovators in this room are your future. They are that statement in living, breathing reality. Stanley, Caesar, Dr. Ali, Dr. Njihia, Dr. Mike, Dr. Muthoka. And now it's my distinct honor to invite a leader who embodies the spirit of Harambee and the very first adopter of Proximie on the African continent, where 7 other countries in East Africa are jealous of what it is that you have been able to achieve. Her Excellency Lucy Mulili, Deputy Governor of Makueni County, the floor is yours. Welcome. And just to say, we're going to keep things on time today. So everyone's got 6 minutes to speak. And we will be sitting there with the screen to show you when you've got 2 more minutes on the clock, okay? Help me not be the bad guy. Your Excellency.
Thank you. Thank you, Shannon. She got me by surprise. I was waiting for the panel discussions. So very well, I'm grateful today. Good afternoon. Thank you very much, Your Excellency, the Governor, Tharaka-Nithi, our partners who are here. Allow me to observe all the protocols, and including the surgeons who are used to this. We are grateful that I'm happy to be here. My name is Lucy Mulili, Deputy Governor Makueni, representing His Excellency the Governor, Honorable Mutula Kilonzo Jr. I'm glad that we also have my team from Makueni County. Most of them are here, the others out. But I'm glad that we've been able to, as Makueni County, to partner with Proximie, and I'm glad that as it has been alluded earlier, that Makueni is the first county, the first subnational government county, rather to pilot this in Kenya, but I'm also told in Africa, as I heard Dr. Shannon say. So we have embraced technology, and it has cut our, of course, HR costs, because you can't have experienced surgeons in every particular hospital. And I'm glad that out of what is happening, they're able to skill one another and be able, at Makueni County, they're able to give direction, the senior surgeons giving direction to the other surgeons. And it is truly has worked for us. One of our Dr. Doris Mbidi, she's one of the obstetric gynecologists. And I know she has done lots of surgeries, and I always, His Excellency Governor Mutula always speaks about what he has been able to go and observe during the surgeries being done. Of course, I must, take note of Dr. Mudoka, again, the neurosurgeons, and not saying others are not doing their work, but I must take note of that, because we're glad that we're able to do, I don't know what you removed from someone's head, but we are grateful. Now, let me say that among the 5 hospitals that have been piloted Proximie within Makueni County, we have seen real benefits to the people, but also to the medical professionals, because it really makes your work easier. And we are glad that this technology is now being rolled out in 5 counties, and many counties are on the line requesting similarly. His Excellency Deputy Governor Busia County was just here. Of course, the issue of stable internet connectivity has been raised here, and so that we do not have sometimes when there is no good internet connection. Now, I want to say this, and to the surgeons who are here, I think you have an opportunity again, because we know even during planning, when the counties are doing planning, you're in the background. Most of you are in the background. You're in the background, busy in the hospitals or elsewhere. We want you to come forward, even as we do budgeting. Tell us some of the equipment. And as we were seated, I heard him say there's something here. Senior said, no, that one is not here in Kenya. I don't know. So please, surgeons within, of course, not county governments alone, but we're working within the county. Be at the forefront, bring your proposals forward, so that even as we implement this Proximie technology solution for remote places, that the counties are able to budget, because we have seen true benefits that you do not, it is addressing the human resource shortages within the counties. So on behalf of the county government of Makueni, of His Excellency the Governor Honorable Mutula Kilonzo, I want to say that we'll continuously use this technology because it is bridging the gap of human resource and technology for better health provision. And I think earlier on during the first surgery, we had the triangle of doom. And I didn't know that I think he was quite blunt. I'm forgetting his name. Dr. Nji here. I mean, he kept us very curious because of the examples that he was using, and I'm glad that today, as we live here, we have a few expressions of the medical of the medical teams that and expressions of what they use, and we have known that going forward as county governments, as partners in health, we can only improve the provision of health services in this country. As the national work on the policies, on the SHA, on the digitization and all that, what we have, let's make it better. Let it work for us. Let us skill and upskill our teams that are working in the counties and in other hospitals. And I hope with the uptake of this technology in this country and elsewhere, in this country, every particular county, I think it can only be better and a better provision of health services to the people of this nation, of Makueni, and the people of Kenya. I thank you all.
Wonderful. Hadi mnaninyongea mic. Wonderful. Hiyo ni yenyu. Ready. Wacha nipatiwe hii. So thank you, Mark, from Makueni to the world. So Makueni has set the pace, and as Shannon was saying, Rwanda and Ethiopia, they are jostling for number 2 because number 1 is gone. So all protocols observed, we want to welcome you to Digitizing Surgical Equity. Next slide. Because we are serious people, we want you to pay attention, but we want to make it worth your time. There are going to be some key facts that the different presenters are going to share. Okay? Now, if you pay attention to those key facts, at the end, there'll actually be a quiz. We are putting our money where our mouth is. There's actually going to be cash money. Cash money, which you'll go out, you can go to the amphitheater that they are building and have some buta. Now for a year. So now, for us to be able to do the quiz, we're going to have to, bring our phones out and log on to Slido. So next slide, let's see if the Slido comes in. Go next, we'll come back to our distinguished guest. Next. Wow. Next. Which PowerPoint is this? Next. Go back. Now you're embarrassing me in front of the governor, the deputy governor, Shannon. Wonderful, wonderful. On your device, provided it is not a kabambe, let me just confer with my team a bit. So as the technology gets sorted, several things that we want to do. Yes, you can still go to slido.com and then you'll put in that number. But I want you to go ask your neighbor, which county are you from? Now, I see people are still on their phones. It's fine. It's good. So I'll give you a minute or two. A minute or two, Slido. Or to go back to the number.
Did it work? Good afternoon. Did it work? Great. So we proceed as Gia and the team fixes Slido. Your Excellencies, all protocols observed. Thank you, Your Excellency, Deputy Governor, for the words, especially for calling upon the surgeons to come to the front. I think that was the clarion call for us. We are now going to hear not just from the pioneer county, but the question that is lingering is, can this be scaled? And we want to hear from the leadership of the county. So we are going to request His Excellency Governor Mudomi Njuki from the leadership of the Council of Governors to give us his remarks, seeing what we've seen and listening and hearing what we've heard. Is this something that we can scale up and spread across the counties to support and digitize health? Please put your hands together for the governor.
Yeah, thank you. First and foremost, I want to apologize on behalf of the political class who has kept the professionals waiting. We are not very conscious of time, but just bear with us. That's what we do for a living. We should have been here by 2 o'clock, and definitely by now you should be finishing. But I'm sure you enjoyed yourself watching live surgery. Her Excellency Ling Tabofield, the Deputy British High Commissioner to Kenya, Dr. Michael Mwachiro, the President of Surgical Society of Kenya, Dr. C. Kaisa Bita, Vice President of Surgical Society of Kenya, Ms. Faith Gitonga Nyakongu, Interim County Director, the Deputy Governor, Excellency of Makueni, you just spoke on behalf of my friend and my colleague, Utula Kilonzo, and all the health ambassadors who are in the room. Good afternoon. I stand here with a lot of gratitude, definitely, to be among the counties that have benefited from the Proxim in terms of having this technology installed in one of my hospitals. But I also stand here as the chair of Health of Council of Governors and to take stock of the good technology that is, or innovation that is working in a few counties. And I'll definitely be an ambassador for you and an advocate when we are meeting as a Council of Governors, right from the Health Committee to the full Council. Because if technology is working, we should spread the good news, we should spread the technology, because unlike us who have counties, our patients have no boundaries. They choose where to go depending where they can be assisted. We could be talking about technology working today in Makueni, but their patients of Makueni would prefer to go to Kajiado because of the distance. We could be having patients in Tharaka Nithi County who would prefer to go to Meru and Embu because of the distance. And therefore, we talk about the patient space that has no boundaries, because that is how our population is like. We are not confined to our counties when it comes to our medical needs. I'm not a medic, and therefore I may not be having a lot of knowledge on the technology that we have, but I have an understanding what it can do for our people, both in our county and in Kenya. For one, we are a country that is not as advanced as our funders, or rather our sponsors, the British and your other partners, because one of the biggest issues that we do have as counties is a lot of needs, but with minimal resources to meet those needs. And one of the biggest needs that has been alluded by the Deputy Governor of Makueni is the HR who are qualified to be able to do surgery. When I make advertisement and I need a surgeon, I usually get 3 times or 4 times of the numbers that I need. Yet I'm not able to employ all of them because I have limited resources. So if technology has come that can be able to assist us have assistance outside the county by having telesurgery or telemedicine, that is a technology that a lot of us will embrace. We have installed this. You have installed this in our main hospitals where we have the surgeries being conducted by surgeons. You'll be surprised that they are the few surgeons that you find in the county who are located in the headquarters. They usually commute to the other remote facilities who equally need the service, but are not able to afford those surgeons. And as much as this is the correct thing to do in terms of putting this in our headquarters, it is an inverted pyramid in that we need them more in those rural setups where we cannot be able to get the surgeons and we do not have adequate funds or funding to be able to do quality labs, quality theaters that can be able to carry out surgery. You'll be surprised to know that even our blood banks, they are better equipped in those level 4 and level 5, which are usually referral in nature. The other small units may not be having reliable blood banks because you cannot have surgery. You don't have a reliable stock of blood that you can be able to use in case of you need to do infusion. And therefore our appeal, even as we appreciate so much, is that in future, as we progress, can we consider the small level 4s and level 3s that are more remote, so that we can have that not just being led now from like where we've seen from London and Makueni and Mombasa, we can have it within the county, inter-county, so that it is possible for our surgeon to be able to do that in the lower levels as they're being guided from this other level. I say this with the conviction that the landscape of professionals in Kenya, if you're not aware what Devolution has done to the health space in Kenya, qualified professional medics usually prefer to work in cities where they can be able to attend to more patients, and they can also be able to set up their private clinics, which will attract more patients vis-a-vis the rural counties where we don't have very many patients who are consumers of their services. And therefore, the rural counties in Kenya, including, in fact, the ones you've gone to, Makueni, Homa Bay, Tharaka Nithi, if you ask these surgeons, you are seated here, Dr. Modoka can tell you that he would take a job any day in Nairobi, Mombasa, than take a job in Garissa or Wajir, because they have access and very quick access to the other clients and even their colleagues or peers in the cities. And therefore, this technology comes to solve that problem for us. Because if you are a county with money and you can't be able to attract the correct technology and correct personnel, then you have no choice but to adapt technology. And this is why we feel that this is technology that not only be in a few counties, but actually be able to spread to the other counties as well. Quality theaters. Until recently, our counties have been having very poorly equipped theaters. It is something that we have been able to live with for quite some time, which is not very good for our patients. If we go to a county like Makueni or Tharaka Nithi, and I can see my staff here, you can attest that you will not find more than 4 theaters in the whole county. And those 4 theaters are in only 4 facilities. Yet we have 115 facilities. After that 115 facilities, at least 35 qualify to have a theater. But the affordability of equipments, quality equipments, updated in technology, has been the biggest problem. And we want to thank what has been put together. I mean, to hail it and thank the owners of the idea that counties can now be able to get equipments without having to buy or lease, by having vendors placing them, and they get what we call fee for service. That is what is in to support this. The equipment I've seen here, very few counties can afford them. But if we have vendors who are willing to place them in our theaters and they are paid according to how many patients have undergone surgery, and SHA is paying, which means the patient can be able to afford because definitely they have enrolled with SHA, then they will eventually recoup their money and patients will have gotten the service from top-notch military-grade equipment that we cannot afford as counties. That is where we are going. I'm saying this because of Proxim and Excellency, even as you give us the technology, you will find very many places where they tell you we do not have the theater. Please tell them. All they need to do is just enroll their need with the Council of Governors, and we'll get them vendors who can place the equipment after doing the survey of the number of patients that can be able to use equipment. And we are doing that so that we take advantage of our numbers, because as one county, you can't be able to do much. But if a vendor has placed equipment in several counties, then the advantage of numbers makes business sense to them, and our patients are definitely going to be getting the same quality as those in the cities. That is where we are. I know there are questions that have been put aside for me. I will allow humbly to be allowed. After this, I will sit in and listen to Excellency speak. But during the panel session, I've requested my CC, who is a medic, can be able to sit in, who has been in charge of that technology, Dr. Nduraku. He will add more value than myself, because I'll just talk about the economics, the affordability, and the challenges of HR, which includes the perennial strikes that we have for the surgeon. Dr. Nduraku, even when your staff are on strike, with this technology, you can still be able to do surgery. It is possible. I'm telling you. So this is the way to go, because this solves not only the funding gap, it also solves the problem of the HRH that we are dealing with in our country. With those few remarks, I would once again want to thank you very much. and tell you, Excellency, we embrace this technology and we appreciate and we hope and we pray that you can be able to roll out to many, many other counties. Because as one county, we cannot be able to solve the problem of Kenyan health need. Thank you very much and may God bless you.
Thank you so much, Your Excellency. Another round of applause. Thank you so much. It's now my pleasure to invite the President of the Surgical Society of Kenya, Dr. Mike Mwachiro, to make his remarks and invite the next guest. A round of applause for Mike. Karibu.
Good afternoon. Good afternoon. Good afternoon. So, noted excellencies, all protocols observed. Excellency Lace Stubblefield. It's not working. Okay.
Yeah.
Okay. Yeah, that's better. I can hear my own voice. So thank you all. Governor Muthomi Njuki, Deputy Governor Lucy Mulili, Excellency Lace Stubblefield, and other notable guests who are present. We want to thank you all. And I think before I make my remarks, I would like to recognize those who've joined us. I know the CEO of COG is also here. Asante. Any CECs who are here, there are many. CECs, asanteni sana, karibuni. Directors of health, yes, asanteni sana. And any other government officials we've left out? Secretaries, yes. Chief Secretary, Chief Officers, yes. Asante sana. Yes, Mike. Karibu sana. I think on behalf of the Surgical Society of Kenya, we are truly honored that you have joined us for this session. Today, we will be talking about something that, as Shannon said, all of us at some point will go through. Who here has had surgery? I've had surgery myself. Okay. Who knows a relative who's had surgery? Okay. Who knows a friend who's had surgery? See, almost everyone. So surgery is part of our lives. And I think until you become a patient and you go under the knife or you take a loved one, then these realities sink closer. While primary healthcare and non-communicable diseases often dominate our health agendas, surgery is essential to a functioning health system. And I think you've seen why. Surgery addresses life-saving emergencies. We've talked about obstetric emergencies, trauma. Last week we were this morning with the governor for Kisumu, and he was telling us about the bus accident that they had in Kisumu town. Cancer. You've just seen a case for a patient who had abdominal cancer. We also know that globally, 5 billion people lack access to safe and affordable surgical care, and therefore delays or lack of surgery contribute significantly to preventable death and disability. So the goal is that when surgery is needed, we ensure that our surgeons and the teams that are fully equipped to serve these patients are there. I will interrupt my remarks to welcome Governor Nyong'o. Karibu sana, makofi tafadhali. Karibuni sana. And so, as I was saying, when surgery is needed, we have the teams that are needed to carry out these surgeries available in our community. Now, surgery tends to be siloed because, we focus on these health systems. But now, as the Surgical Society of Kenya, we have recognized the need, and I think, Governor Njuki, you've brought this out, to be there at these tables when the policies are being made, that we're able to be part of these discussions. And so that half the time when Parliament is voting, I'm in theater, and I ask, what have they said? And then we catch up. But we are asking, how can we be part of these discussions and contribute to these agendas, and so that we are able to impact care in the country? And so as SSK, we've been asking the question, how can we be engaged in policy at the county level, at the national level, and at the local level. And every year at our conferences, we have these discussions. Now, we would like to continue working with the Council of Governors and what they have been able to do in this country. We are grateful that through our partnership and collaborations, events like this have been able to come to life. Makueni is an example of where this has been, shown to work. And so we look forward to continuing these engagements. And we are really grateful, for the opportunity that we've had to leverage on these collaborations. What is Proximie? I think you've seen it. We've shown you practically what Proximie is. Proximie is this wonderful system, and it integrates technology, surgical skills, because you have the surgeons operating behind the technology. We've shown you examples of mentorship, and I think Dr. Mudoka has given an example from his own case. And later on, you'll hear from Dr. Abdulaziz Ali, who is based in Makueni. Proximie is a secure system. It's cloud-based. And this platform allows, as you've seen, real-time participation in operations from anywhere in the world. And today we've shown you Coast General to here, United Kingdom to here. And in the past few months, we've done many, many examples of these kind of surgeries. As you've seen, you have, and actually we have it here in the room. We usually have, this is a standard setup. The white camera you can see there, that's a PTZ. It is able to zoom in and out, so you don't have to move from where you are. It can pan around. So it's called pan, tilt, and zoom. Can go up, down, left, right, and zoom. We have multiple video feeds. You saw in the morning, in the afternoon, I was wearing the PX lens, which allows me to see what I'm looking at. We have the BS bot, this little one. You can actually teach it to follow you. And it's really cool if you're giving a talk and it follows your face. And so if you want to look really cool in a presentation, you can set this up to your phone and then stream that. And it's very fancy and I love it. I have one because I harassed Shannon until she gave me one, which I now carry with me when I go to remote theaters because I can set it up and be able to have a traveling Proximie session. Finally, the ability to draw, annotate, point, and give live verbal instructions. And so today you've seen live cases from Mombasa and the United Kingdom, and each of these highlighted different aspects of the surgical continuum. So as we move to the next few sessions, we want to look at Proximie, surgery, and how these two interface, the lessons we can learn from clinical technologies in our own context, the infrastructure needs, as has been pointed out a few minutes ago, and after this, sustainable, skilled clinical innovators have the space to work. There are many digital health innovators in this room. I think I had Neopanda. Where are you? Neopanda, yes. Ben Roberts is here from Liquids. Thank you. Safaricom are working around at some point, and many others who are working with us. And so I want to ask, if you're in the digital innovation space, please put up your hands. We want to recognize you. Mr. Gakombe is here. Yeah, asante sana. So thank you all. Yes, Noel, thank you. Open Fences. So as I finish, this is a call to engage. We want this to be interactive, as it has been so far. We'll have a fireside chat a few minutes from now. This is a conversation about how we can scale innovations in real, pragmatic ways. And it's about all of us, the audience. So we want to engage in these discussions together. And I think I will repeat this as I finish. I want to thank the Council of Governors Health Committee led by Governor Mudomi Njuki, Governor Nyong'o, Deputy Governor Lucy, and all of you who've come here to support us in this. And we want to, as we go to the next session, we'll focus on a few key things which highlight what happens in the counties. One of them is Dr. Abdulaziz. I don't know where he is. Right there. He'll be talking about a life-saving story from his own experience, and we will let him share that. Dr. Mudoka has shared examples from his own. Dr. Mwatha from Makueni, they have these PPH programs that they've been doing. And so we want to learn from each other. So I will finish by saying, asante sana, erokamano. And we are grateful that you have joined us in Homa Bay County. The Homa Bay County, it's politically correct. Homa Bay County, that you are here together to be able to learn. Asanteni sana. And because I'm up here, I will take this chance to welcome Her Excellency Lee Stubblefield, Deputy High Commissioner from the United Kingdom. Let's give her a warm round of applause. And she will be giving her keynote address. I would have asked them who here are English fans of football, but
Don't. I'm a very sad fan of Newcastle United, so we don't talk about it. But thank you very much. It's a genuine pleasure to join you today in Homer Bay County at this brilliant conference. I have to say I went to the last one in Eldoret, and this one just seems bigger, like really big, right? And it's been great. I have met so many really interesting people, and you should all be so proud of what you do. So it's been lovely to join you, if only for a very short time. So I just wanted to say that you will hear a lot and you will see a lot, perhaps a little bit more than some of you bargained for when you walked in, about the incredible technology that is being applied here. But actually, really, what this technology is about people. And I think Dr. Ali's story that he will tell you a bit later is actually, it's quite easy to get a bit carried away with all the gadgets and the sort of clever connections, but it's about people. It's not just about the surgeons, it's also about the patients. And I think that's what's been really inspiring for me over the last couple of days when I've met with the surgeons and with the Proximie team, is that they're all so passionate about this. And it's not really about them, it's about a system and it's about the people. And I think we could really celebrate how that technology and that collaboration and the trust that it requires in this system can transform healthcare delivery. And as we've seen, that can be in remote areas. Surgery, as we've heard from the Deputy Governor from Makueni and from surgeons themselves, is not often discussed. And it's fundamental, though, to a functioning health system, as many of you will know yourselves. And yet we can see here in Kenya that many people are several hours from a surgical facility. And as His Excellency Governor from just spoke about, rural counties continue to face challenges in staffing and in equipment and in technical support and mentorship. But these challenges are just not unique to Kenya. In the UK, where I'm from, our National Health Service that we were looking at earlier is currently managing over 112,000 staff vacancies. And we have more than 7.5 million people on surgical waiting lists. So this isn't about a UK company coming to Kenya and telling you how to do things better. This is about a genuine shared challenge that calls for international cooperation. And that's why the British High Commission and the UK government is really proud to be a part of this. I think if we are looking to achieve universal health coverage, we cannot not look at the need for equitable access to surgical care. And Proximie provides an opportunity to think about that a bit differently. So Proximie originates in the UK's National Health Service and is now deployed in over 800 hospitals across more than 50 countries. And in Kenya, thank you to our colleague from Makueni, because that's where the journey began. And the governor there took bold steps really to digitize surgery, connecting facilities, empowering clinicians, and enabling real-time learning. And we've talked today and with others over the last few days about some of the issues around that, about solar power and connectivity and the internet. But despite those challenges, Makueni's model is being studied across East Africa. As Shannon has said, 7 other countries are exploring similar approaches to digital health. So it's always great to see Kenya in the lead, not just in the London Marathon, in fact, in every marathon, but in many other fields as well. So I think, just as the Governor, His Excellency, just outlined, the Council of Governors' roadmap to scale Proximie and connect surgical services nationwide is equally positive. And I'm so grateful to the governors and deputy governors who are joining us today. I know this is a huge event and there's a lot of pressure on your time, and we really, really appreciate it. And to the Surgical Society of Kenya, now partnering with counties to lead this integration and ensuring surgery remains central to health policy and innovation. Thank you. I think it's a demonstration of devolution at its finest, counties collaborating, sharing expertise and improving outcomes. In short, stronger together. So I don't want to say much more, except that I think for us, as I said before, technology alone is not sufficient. And these partnerships are really at the heart of this and taking that forward. And Shannon mentioned partners such as the Amazon Web Services and the Kenya Education Network, and how we are learning from them and rolling those things out. And I think from my side, it just remains for me to say that to all our Kenyan partners here in the room, but to all partners from across the piece, actually, we're honoured as the British High Commission to walk this journey with you, from policy to practice, from Nairobi to every county represented here today, I hope. And I have to say this because it's a bit cheesy, but every single time we have to do a speech at the High Commission, we have to say, we go far when we go together, and then that will appear in our hashtag. So that's my job. But asanteni sana, and thank you so much all for making the time to join us at this event today. You're not going to ask me difficult medical questions, are you? You can you're offering to fix my finger.
So for Her Excellency Lee, ready. I have the microphone back. You know what that means. Very dangerous. So, all protocols observed. My name is Dr. Njihia. By public demand, we want to see live cases. Now, here's the thing. The cases that we saw today are uploading. So you have to imagine that each file is around 10 GB or so. So that takes a bit of time to be uploaded. But here's something. We have a video pointing out intestines and gallbladders. And so everyone learns. And that's why people are excited here. I think over Christmas, when they look at goats, now they're going to say, is this goat grass-fed? Because then you can know what a fatty liver looks like. Yeah? Yes? Yes. So let me orient you. This is now my dashboard, Dr. Nji here. And the cameras, as Dr. Mwachiro was explaining, you have a camera that looks at the room. So you can always see who are all these people, who are these layabouts in the room, who isn't earning their salary, things like that. Then there's the camera on top of the operating table. And now for the surgeons, this is what's important, because a surgeon dialing in can look and say, are you putting your instruments in the right place? And then this is the view of inside. Now, here's an interesting thing. When we went in, this is a lady who'd had recurrent bouts of cholecystitis. Her gallbladder was inflamed. And that happens when there are stones in the gallbladder. And here's what they hadn't told us before. She'd had multiple other surgeries. And so what happens is the same way you scar on your skin is the same way you scar inside. And so she had a lot of scars. So here's the thing. The first camera we put is here near the umbilicus for the video. And a lot of the time, we need to put another port there. But as you can see from our view inside, everything is stuck. And so after we'd put this port and these two other ports, I called my colleague in Nairobi, called Dr. Hussein, and I said, Dr. Hussein, I don't think we can finish this surgery using the camera. We'll need to do the old school one. And now, because Dr. Hussein is a bit braver than me, said, what do you mean? I said, go ahead and try and finish it using the camera. And so with that, I got confidence. I said, someone in my ear has said, go ahead. And so what you can see us doing is releasing the gallbladder slowly. We were able to release. Remember we talked about advanced energy? The two scissors now. Now this is different. Remember the other one was using ultrasound, vibrating. This one sends between those two jaws, there's electricity and it just burns between those two jaws. So it's safer than just going in with energy. We call it monopolar, bipolar, but the energy is just between those two jaws and allows us to divide tissues. Again, same with cancer. Remember in cancer, the cells go and say, oh, I'm attaching here, and blood vessels come where they shouldn't be. The same thing with scarring. When tissue scars, there's a lot of bleeding. And so what you can see, this allows us to buzz, seal all the vessels that might actually leak, and then push away. And that's what we are doing. The difference between when you use electricity, steamer, and when you use the ultrasonic shears, so this is actually smoke. When we buzz, you see smoke coming in. This was Dr. Mbati here. You can see him saying, go, Dr. Nji here, go. And here we are, and you'd find that this now allows, we managed to do this case with the support of my colleague from Nairobi. And this is the power of Proximie. And what we are saying is, this allows, I have this in my library. When I'm not under the pressure of surgery, I can go and review my case and say, okay, what did I do well? What could I do different? It allows us to do what we call reflection in practice, because as I'm talking to my colleague, we are talking through every step that I'm doing. And then reflecting on practice, which is afterwards I go, I review the video and I'm like, could I do this better? I will tell you, for example, there are times you will go back to this feed and ask yourself, I'm noticing that I'm not operating for like 1 minute. What's happening? I look at my room and I realize it's because there was a supply that wasn't in the theater. My team member had to run and get it. And as a team, you come back and say, look, guys, we know what we need for every surgery. Could we do better and plan better? And as Excellency Mudomi was saying, exactly so, that in a level 2, the consultant in the level 5 can dial in and guide a medical officer through a procedure that they are credentialed to do, whether it's a cesarean section. Now there's a lot of bleeding, and that's what the team from Makueni is going to talk about. Then that's how you strengthen the care delivery within your unit. And that's what you missed in the morning. Ready? We're going up to the panel discussion as Mike comes in. Put the Slido now. Go to Slido. I say there's money, so you better log in. There's money. Put it on presenter view. Let's see the counties that are now represented as the panelists are about to come in. Governor came with an entourage, I see. No, go back. Which county are you from? Back. Whew. Governor Mudomi, you have come with your entourage. Is your county there? Yes? So, Sarakanithi, ready? Nairobi, ready? Hey, Makueni is coming from the back. Hey, Homa Bay. Homa Bay is coming there. Kirinyaga has 1 or 2. Nairobi is also strong there, but we can see that. So, Mike, I'll hand it over to Dr. Mwachiro, President of the Surgical Society of Kenya. We'll have this running even as the panelists are coming. Join at Slido. Don't miss out on money.
Yeah, so I think we can set up the panel session. So I'm going to ask our panelists to please come up and join me on stage. Deputy Governor Lucy Mulili, Governor Mudomi Njuki, Dr. Caesar Bita, Ms. Faith Gitonga, and Dr. Abdulaziz. Oh, okay. So as they settle, I'm going to ask Governor Nyong'o to say a few words. Yes. Yeah. Not from there. There's a ramp or yeah, we'll bring the podium down here. Yeah. we have hijacked. So Prof, karibu sana. Here is the microphone.
Thank you very much. Well, thank you very much for hijacking me, actually. This is something I didn't want to miss, but there are so many things going on that you may think that you're in a very good session, but another better is going on somewhere else. So, Kata, thank you for reminding me to come. And now, I have to pay the price for coming. I'm going to say this on behalf of my friend Mudomi Njoki, the chair of the Health Committee of the Council of Governors, and Governor Tharaka Nithi. Her Excellency, the High Commissioner for Great Britain to Kenya, Leigh Stubblefield, and all the others, all protocols observed. Good afternoon. It's a great honor to join you today at this important side event on digitizing surgical equity as we collectively shape the future of healthcare through the transformative power of digital innovation. And I must say we have this thing at Jaramogi, teaching at Refa Hospital in Kisumu. As I was watching it, I just realized that yes, there's something similar to what is going on in Kisumu. I asked Dr. Ganda. Dr. Ganda confirmed. I knew I was now in the right place. In line with our national journey toward digitizing the healthcare system, we are not merely adopting new technologies, we are fundamentally reimagining how care is delivered, accessed, and sustained across the communities we serve. Across our counties, the realities remain stark. Many patients in rural areas travel hours, sometimes days, for access to surgical care. Facilities are often constrained by limited theater space, inadequate equipment, and even more by specialist shortages. And yet, from these very constraints, innovation continues to emerge, bold, locally led, and digitally enabled. I must thank Dr. Ganda and his team that some of these shortcomings are very quickly being overcome. And a technology like this helps a great deal to support the initiatives they are taking, notwithstanding scarcity of resources at times. Today marks a paradigm shift as we engage with Proximie Limited, one of the key digital enablers in our counties. Through their work, the conversation around digital health has moved beyond technology. We are now witnessing real-time learning, mentorship, and knowledge transfer directly at the point of care. I don't think I could ever have been a doctor. The sight of a liver, in Dulu we say kidney, the sight of a liver moving would have scared me to hell. But thank God I never took that profession. Through platforms like Proximie, experienced surgeons can share their expertise with junior colleagues remotely without incurring the cost of disruptions of physical travel. With only the cost of internet connectivity, now increasingly accessible, this model has proven most cost-effective and scalable. The results we speak about for themselves. In Makueni County, for example, I was sitting next to my sister there and we were chatting, and she said, they have this thing in Makueni County. In Makueni County, an 82% efficiency improvement was recorded in surgical care following the adoption of digital tools under the Safe Surgery Program. Counties such as Tharaka Nithi, Homa Bay, and most recently Garissa have launched similar technology-enabled surgical hubs powered by remote collaboration platforms and cloud-based solutions. These successes are made possible by strong partnership between county leadership, innovators, and professional societies. Next time this speech is written, Kisumu will be one of those counties that should be mentioned. As county governments, we continue to grapple with systematic challenges: a shortage of specialists, limited training capacity, and significant inequities in rural surgical access. We therefore require sustainable and scalable solutions. Successful digitization must be patient-centered, integrated into health systems, and supported by long-term commitment at every level. Let me repeat. Successful digitization must be patient-centered, integrated into health systems, and supported by long-term commitment at every level. Ladies and gentlemen, Proximie is one such solution. It is a secure, real-time surgical collaboration platform that allows surgeons, mentors, and trainees to observe, listen, and interact during live procedures regardless of geography. Proximie's continued presence, working alongside our counties to troubleshoot, adapt, and grow, is the kind of partnership we must champion. Just last week, a surgeon at Coast General Hospital virtually consulted on a neurosurgical case being conducted in Makueni without leaving his operating theater. Makofi basi. This is the future of our healthcare system: seamless, real-time collaboration across counties. This initiative also helps address one of our greatest barriers. That is, the reality that our health workforce often cannot leave their own facilities to train others. With digital surgery, mentorship and consultation are now consistent, live, and accessible. In other words, given some kind of shortage of human resources at very high levels, this kind of technology helps to bridge that gap. Mabwana na mabibi na wale wasio na mabibi, as chair of the Council of Governors Health Committee, I remain committed to ensuring that no county is left behind. Sharing infrastructure, aligning with national policies, embedding digital tools in budgets, and partnering with professional bodies. Innovation without sustainability is just a headline. Counties need stable financing, infrastructure, and continuous training to make these gains permanent. It is our responsibility, ladies and gentlemen, as duty bearers, to take the next steps to consider how we co-create the enabling environment for such programs to scale across all counties and support our surgical teams and workforce to access the training, the mentorship, and support they deserve by making surgery a fundamental priority of our health systems policy and agenda. As I conclude, and as I must conclude, digital health is not about technology alone. It is about equity, access, and dignity. With the right tools and partnerships, county governments can lead a transformation, not just in surgical care, but in the entire healthcare system, grounded in connectivity, shared expertise, and trust. Together, let us ensure that no Kenyan is left behind, no matter where they live. Let us connect our healthcare providers, equip our facilities, and build a future where every citizen can access care, safe, timely, and expert care. Asanteni sana. Mungu awabariki.
Excellency, as you stand here, hiyo ni yenyu, yetu ni radi. Protocol nitolee hii. I want Prof to stay here. There are some photos we have to to take with our esteemed guest, Chair Emeritus. So 2 photos. First, we'll have Chair COG, the team here, and the CEO. Yes, COC. Karibuni, karibuni. Then the next one will be SSK and the secretariats from the counties. So SSK and secretariat from the counties of Makueni. No, that's the second photo. I have been told I can also. Not then. Just wait. Just wait. There's still a photo here from Dr. Ganda. So now, secretariat, SSK come. If you are in the secretariat of Makueni, Kisumu, Tharaka-Nithi, just to confirm to your boss that you were also here when he was here. You were also here when she was here. Show yourself. If you are not in the photo, then you are not here. You are eating mbuta. Your boss was here, you are eating mbuta. Ensure that you are in the frame. So some of you can go behind. And because this photo might come on the Caravision, I need to be seen. Boma isisambaratike, boma isisambaratike. Say Proximie. Proximie. Ready. Thank you. As had been stated before, I know Governor Muthoni Njuki is leaving us, but Professor Nyong'o will be in to discuss. So our panelists, can we still go up? I know Her Excellency Lee will still be here. Someone say money. Someone say money. Hiya. I know you're thinking it's a joke. You think it's a joke. We are talking serious things. So Mwachiro, you're all set? Thank you.
Asanteni sana. So we will move on to the next session. And because time is fast spent, I will try and move this a little bit faster. So this is supposed to be a fireside chat. So we're actually missing a little fire. You guys are not getting this joke. Anyway, so this is a fireside chat, which means we'll just have conversations. And I think the panel has rearranged itself a little bit. So I'll have them briefly say a name and where you're from before we start. Just because we've reconstituted it. So I'm Michael Mwachiro, President, Surgical Society of Kenya.
Good afternoon, everyone. My name is Faith Nkatha Gitonga. I work for Tony Blair Institute as the head of tech and the interim country director.
Good afternoon. My name is Gechuya Durak-Mutwariara. I work for Tharaka-Nithi County Government as a CC member for Public Health, Medical Services and ICT. And I am an admirer of minimally invasive surgery. Thank you.
Good morning, everyone. My name is Dr. Mwatha, Director Preventive and Promotive, Makueni County.
Good afternoon, everybody. I'm Dr. Ali, a medical officer in Kambu Sub-County Hospital in Makueni County. Thank you.
Dr. Caesar Bita, I'm the Vice President, Surgical Society of Kenya. but I'm a general surgeon at the Jaramogi Oginga Odinga Teaching and Referral Hospital in Kisumu. Thank you.
Not working too well. Okay, so to set us off, I think this question I will ask Mwatha. We've discussed a lot about budgets and prioritizing budgets, and I think one of the comments that was made is how do we plan for this kind of digital technology and innovations in our counties? So, from your perspective, what are your comments on this planning, budgetary needs, and preparing the counties to be able to do this?
Mike 1, 2. Mike 1, 2. Yeah. Okay. Yeah. So one of the few things, and this was one of our learning lessons as the early pioneers in adapting technology, is as we introduce technology, there's a lot of high-level advocacy that has to be brought in. We had to onboard from the governor for him to understand what we are talking about, advancing technology and what that entails. We had to embolden the health committee because that's an important component when you think at county level budgeting, what that will mean. And then we also had to onboard the consultants who are going to be using the technology, because it's not just about putting a technology in a county and pasting it there. It's for them to understand what that means to them and what effective means in terms of implementation. After we get the mainline consultants on board, the other bit of people that we had to bring on board were the medical officers who use the technology in such a way that from a lower facility, because how our budgeting cycles will work is health facilities will come up with their work plans, and then they bring it at HQ, and then the HQ will present it to the cabinet. So we had to bring the whole cycle of the users of technology on board. So that now creates that budgeting component to be implemented for sustainability, because it's not just the gadgets. There's the electricity component, and in case there's no electricity, the backup generators and the internet connectivity, because that then becomes a key main driver, and especially for the lower facilities which are going to be using this technology. And those are some of the conversations that have to be put in, so that as they budget, they have to ensure that we have connectivity that is effective in terms of ensuring that there's sustainability as we think on advancing technology and putting budget lines for them.
Okay. Asante sana. And maybe we'll cross over to Tharaka Nithi. And I'm going to ask a slightly different question, but it's connected to what he said. And the question is, when we have so many different competing things as a county, and especially priorities in healthcare, what kind of evidence does the county need so that they can be able to build policies and budgets to be able to support this kind of innovative changes?
Thank you very much. Thank you very much for that question. I think it is important that each one of us in this room understands that anything you do or fail to do affects health. Whether it is roads, whether it is water, whether it is agriculture, everything you do or fail to do affects health. And that is why we had this slogan very many years ago, health for all and all for health. That was the WHO slogan many years ago. So to come back to your question, my approach is that we look at the entire disease burden, because we have data collection. We look at the disease burden in the entire county, and we start asking ourselves economic questions. When these people lie down in their homes without going to hospital because they are sick, how much of economic loss is this? And if we invested in health, in various aspects of health service delivery, how much then would this county reap if all these people were productively, applied in their areas where they work? And you know very well that you don't even have to be an economist to really figure out that, the lost so-called men and women hours because of sickness, the disease burden, has a very devastating effect on the economy of the county and also the economy of the country. So for me, my first approach is to tell His Excellency the Governor because I also swore to advise him that we need to invest in this aspect of health service delivery so that we can be able to improve the economy. Now, by virtue of being slightly older than some of you, I have actually an experience in our health systems in this country where we never even had any very minimal technological advancements. You'll be surprised to know that even talking of an ultrasound machine, the first one was donated at Kenyatta National Hospital, I think 1981, and it was very blurred. And there was only one person who could, who could do the scan. And and that's the time that we used to do, for those of you who are gynecologists, those are the times we used to do the so-called ELP, that is erect lateral perovimetry. And this was in pregnancy. I'm a gynecologist by training. So you can see where we have come from. You could not image. Imaging these days is something that you think is just an obvious thing. But with the hindsight, you can see we have attempted to advance in terms of technology, but we are not moving fast enough. There's a time that this country had a policy that every district hospital must have an ultrasound machine. That was around 1988, 89. And I remember I was hired by Johns Hopkins University as a training coordinator for GPEGO, and I donated on their behalf 4 laparoscopic machines in every district hospital in this country. And I was supposed to be covering Tanzania and Uganda. But then the understanding was, once the collaboration between GPEGO and the Kenya government expires, the Kenya government was supposed to make sure there is availability of laparoscopic machines as a tool for diagnosis and minimally invasive surgical operations. I was actually training in minimally invasive surgical operations that time at the University of Nairobi. But if you look at the machines that we were using that time and compare with the sizes these days, for example, the trocar and the cannula were almost like a weapon of mass destruction because it was huge, And even as you drill the tummy, you could see that you leave a very big scar, more than the 2 centimeters we were talking about that time. So for me, this kind of technological advancement and this kind of mentorship that we are talking about, I look back and see every time a specialist used to graduate from the University of Nairobi Medical School, when you go to your area of work, let's say this and that district, you have to be accompanied by your teacher who used to see patients with you for a minimum of 3 months. And there was money set aside to pay these teachers stay in your district hospital. So we never used to just release a student, a surgeon, and be left like that. So when you are talking about using the technology to do mentorship, to share, etc., we are trying to play catch up. And of course, I'm not here to discourage anybody. I'm here to say we need to move with speed, because there is no way we can do without technological application in medical practice, whichever branch of medicine you are in. Okay. Thank you.
Makofi tafadhali. If we can get a second mic, it will really help us here. So I'm going to move to the private sector first before I cross over to the surgeons, because you've raised some points here. And I want to ask Faith, because she's from the Tony Blair Institute, and they have been engaged in shaping Kenya's digital policy, because you've talked about many things. And I want to ask you, having listened to what they have both said, could you share the work that you have done in Kenya to date? And how does this align with how we are, the Kenyan digital superhighway goals, and how it interacts with the healthcare system?
Asante. First, I'm very honored to be seated among doctors. And thank you for your inputs. So as Tony Blair Institute, we say that we help leaders get things done. Because like you said, if you think about the health sector, for example, there are so many priorities. If you think about the number of things as a governor you would need to do, just in terms of health, you could probably come up with a list of 100 things. And so what we do as Tony Blair Institute is to figure out what is really priority, so then that way we can come up with 2-3 things, we say up to 5. And what we say is that those 5 things will hopefully then have a ripple effect. And one of the things that we really focus on is policy. So we've worked with the Ministry of Health, for example, inputting in the Digital Health Act. We've worked with Ministry of ICDE to see how we can engage with the Ministry of Health to then build on, this digital superhighway. There's the goal of the 100,000 kilometer fiber optic, to just see how do we set up the right policies. And if you check in most of government, a lot of the policies were last, reviewed probably 2012, 2013, around that time. And digital was not a thing then. So just seeing how do we input at that point, and challenge the policy at that point. And we like to call it actionable policies. So it's not just policies that collect dust, but how do we make sure these policies can then, be implemented? And the other thing that we work on as Tony Blair is to then ask the difficult question. I heard him speak about funding and sustainability, and it's then to say, okay, so, there's no, internet connectivity in this county. Then how do we bring in partners? And the partners could be private sector, could be government, could be the donors, to then say, if we bring in this private sector, then we can be able to enhance or go the extra mile. Because if we're to be honest, government can only go so far, and so we have to be able to ask ourselves, how can these donors then support, and how can private sector then be able to support to then bring these things home? And before I hand the mic back, I'm previously a banker, and I also worked in the tech space before the development space. And one of the challenges I keep bringing up when I sit with various government officials is to say that if Kenya is the home of M-Pesa, then we have to be able, we lose hope when we think about how much further we have to go in digital health. I was watching this on the screen and thinking about, the county I'm from. And it's a part of Meru called Giaki. It is so remote. I've actually never met anyone in Nairobi who's Meru who knows Giaki. I don't know if Madam Mary Mwiti, you know Giaki, or maybe you know Giaki, or you do. Very few people know Giaki. Or maybe we are relatives for the people who've raised their hands. And it's interesting. My dad passed on last year, and he was a doctor. And after he retired, I remember seeing him trying to make such effort, to transform the health centers and the clinics in Giaki. And sometimes it can be hopeless. But I think we have to think about quick wins. And that's my challenge to all of us too, with all due respect to the governors, etc. What are the quick wins? If you think about, I can think of an example, maybe like M-TIBA, maybe, where it takes advantage of M-Pesa that all of us have on the phone to bring access closer for health insurance. So what can we do with what we have? I remember in my fintech days, we also used the USSD. How you type star and a certain number hash? And through that, during COVID, people were able to access information. So my challenge as well is that as we wait for connectivity to get there, as we get funding, as we figure out how to use all these different things that we have, how can we then use what we already have and use that to enhance, whether it's connectivity, infrastructure, all these partnerships to then be able to make our counties great and, get access to what we've seen here to the extremes of the country. Yeah.
Asante sana. Makofi kwake. So, I'm going to have them build up on what you've said, because now you've added another element, which is financing. How do these technologies leverage with what we have in our counties? How do private-public partnerships work? And I'm going to ask Dr. Bita, because they have, and he's going to share his experience at GeoTRH with the introduction of minimally invasive surgery. he's looked at that and how does this impact our health economic systems at the counties. And so from your perspective, a couple of things. Could you define for us what minimally invasive surgery looks like? And what are the key benefits for the counties? Because you have the county leaderships, the governors here. What would that look like in terms of benefits of having an MIS service in your county?
Okay. So mine is to share the JOTRH experience. Yeah. Minimally invasive is what we usually call it laparoscopy, keyhole surgery. You may want to add as well endoscopy. So I want to share the JOTRH experience. When JOTRH started off by saying, let us have endoscopy. Yeah. And they brought the tower and they invested in it. In 2024, almost 800 cases were done. Yeah. So these were patients who were initially only going to the private sector for these endoscopies. Yeah. At JOTRH, they pay 5,000. In private, they would pay 17,000, 18,000. Yeah. So the difference per patient was well over 10,000 to access the service. Yeah. That's the first big thing. Then assume JOTRH invested, say, 6 million on this tower. Yeah. And they've done 800 cases at 5,000. Then it would mean that in that 2024, they made 4 million from that tower alone. So if you look at it, this is equipment that is self-sustaining because in less than 2 years, you've recouped your investment. But some of these patients who could not afford to do it in private in Kisumu would end up taking a bus or a matatu to Eldoret, to Tenwek. Yeah, 2 hours drive and everything. And when you go, you know, they go accompanied by somebody who spends 2 working days. You go there and you're told we'll do it tomorrow. So it makes economic sense to invest in this because at the very minimum, it is equipment that returns its costs, but bigger still, the hospital benefits from the sharp payments from it. The county has this revenue not going far. Yeah. If you move to laparoscopy and you move to the digitized one, first, for me it was easy to have it done at JOTRH because JOTRH already had internet. They dedicated a line specifically for Proximie in theater. We've done slightly bigger because we have teaching universities. So we've actually put, okay, you know I'm saying we, yet the person who engineered this is somewhere in the room. The director of clinical services in the room, Dr. Deda Nongo, and he was very keen in this. We put in 2 big screens, one in theater, one in a classroom. So previously, students would peep behind the surgeon. You would be operating, and you have a group of 10 people behind you here who want to peep and see. But what we do, yeah, is like when the first time we did Proximie and Dare went to the classroom to listen. Dr. Dare is a surgeon. Eh? It's so easy for the theater to go on, and I pick 6, 7 students and stay with them outside and teach them. And I am talking to the surgeon in the room. So we have real-time audio video. But the bigger thing, and we were discussing with the CEC, Dr. Ganda, even this morning, next step is to have it in the other county hospitals. Have it in Ahero, have it in Kombewa, because we have young surgeons there who sometimes are not confident to do some procedures on their own. So what do? They come with the patient to Kisumu. They tell the patient, come to JOTRH. It would be easier if this person is operating at, let me mention 2, Kombewa or Ahero, and real time, we are sitting and supporting from far. Economically, it makes sense. In the morning, we saw a hernia being repaired from Mombasa, and then there was mention of the gallbladder. Let me take the example if you're doing the gallbladder laparoscopically, and you have support elsewhere. If you are to open, you know, we used to go, and you remember if you get an injury or surgery in this part of the world, you asked, how many stitches did you get? Okay? So if somebody opens from here till down there, takes you 4 or 5 days in the hospital just to control the pain. But the patient we saw in the morning being operated at Mombasa, by 8 a.m. tomorrow morning, is out, has been discharged home. So every extra day taken is 3,000 to 5,000 shillings extra to the patient in the ward. Yeah. So if you're saving 3 days, you save 15,000 shillings. If it's a hospital, it's even better because whether the patient there is for 5 days or the patient there is for 10 days, SHA will pay you the same amount. So if JOTRH is able to have the patient leave in 2 days, yeah, rather than 5 days, SHA will pay JOTRH the 120,000 and they would have spent less and they have more money to invest into other activities. Thank you.
Wow, makofi kwake tafadhali. So because we are rather old in the afternoon, I think we will move on from the experience in JOTRH to another experience from Makueni. And I want to welcome Dr. Abdulaziz Ali. He is going to give us a frontline perspective. And for him, we want to hear from him about how do we save lives through use of digital tools. So Dr. Ali, you are a medical officer currently serving in Kambu. Could you describe your role, the types of cases that you commonly see, and then tell us your story about how you were able to use Proximie to guide a life-saving intervention?
Okay. I'm Dr. Ali, a medical officer, currently stationed at Kambu Sub-County Hospital, that is in Makueni, very close to Mtitoande, in Kibwezi East Sub-County. So I think as the role for all medical officers in Kenya, especially when you are sent to a sub-county facility, a remote facility, the medical officer becomes the primary doctor. You are the surgeon, you are the physician, you do everything basically. So patients, when they come to you, they don't want to know if you are not an orthopedic surgeon or you are not a general surgeon. They know you are a doctor, so you must be able to do everything. So sometimes it is challenging. And for us, we are close to the highway in Mombasa, the Nairobi highway. So you get a lot of accidents, you get a lot of injuries, you get a lot of emergency cases that you have to deal. And some of these cases are things that we read in books we have never seen. So it becomes challenging for us when you don't have somebody to guide you, when you don't have a mentor or somebody to give you the confidence to do some of these things. So it is challenging, but I think with technology, you are able to consult, you are able to get somebody to guide you and lead you in attending to most of these patients. And I think it might go a long way in saving lives, because we lose a lot of patients, for example, in accidents, motorbike accidents, somebody will have a fractured tibia bone, and we know the bleeding that occurs there. If it's not arrested as fast as possible, you might lose a patient. So I think having something in your back of mind that there'll be somebody who's going to guide me through difficult cases, through difficult times, it gives you some confidence, and also you get to gain skills. So I think I want to allude to one case that I encountered. I think during the initial phases, I think it was the third week of having Proximie at our facility, third or fourth week at our facility. That is Kibwezi Sub-County Hospital. I was there initially. It was on a Saturday, 3 a.m. Saturday, 3 a.m. Very difficult to get a consultant to come and assist you. And then we got a mother who came with a pervaginal bleeding. In our assessment, we could feel the baby was moving around the stomach, so we knew the uterus had ruptured. And the baby was also dead. So the mother was also pale. So she was still bleeding. And we had to act fast. And there was no time for us to refer that mother. So we took the mother to theater, connected the Proximie, logged in, and we called our consultants. Luckily, they were available, 2 of them, obstetricians. So they logged in and they laid her through the case. So we opened, we did see that the uterus was ruptured. And for me, that was the first time seeing a real uterine rupture, that big, that massive. So they guided us. They told us we had to stop the bleeding. We had to remove the uterus. So it was my first time to do a subtotal hysterectomy. So as you said, the cameras, the PTZ can zoom. So the consultants were able to zoom. They told us where to clamp, where to cut, where to stop the bleeding. And we actually saved that mother. So for me, that was the skills I gained. So up to now, I think I'm not an obstetrician gynecologist, but I can comfortably do a subtotal hysterectomy. So I think for me, this technology is something that I embraced 100%, and I will encourage if it can be spread out to all the facilities in this country, because we know we have a shortage of consultants. So if we can use this technology to equip our primary health care doctors, I think it will be a great plus to assist our mothers. Thank you.
Let's give him a round, please. I think for those of us who are doctors, you appreciate, I can picture myself in that. This is truly, truly one of those places when your stress levels are above the roof. So thank you. I mean, a good outcome, we're able to save a life, but also highlighting the power of this tool. So we will wrap up this session. I know we could keep going on, but it's way late, and I know some of you have not had lunch. So I'm going to say, let's give them a round of applause. Asanteni sana for being in this panel. And I will ask Njihia and Stanley to please come up. We had one more exercise, which, and I see some things have been going on up there. Yes, please. We can, yes. I've switched to moderator mode.
Radi ya panelists. Nduru. Teke. Wanasalimiana hapa. Don't worry about lunch money. If you have been paying attention, you can have all the mbuta you want. For us to grow our Proximie network, and for us to bring in as many stakeholders as we possibly can to walk this journey, there are several things that we need to put in place. And so we are going to introduce some work streams. But Excellency, you are seeing, people are saying, what is the biggest challenge? Corruption. So we will interrogate some of these things, but I'll hand over to Stan, because maybe you are seated there, you're wearing a different hat, whichever organization you're representing. You're asking, how do I plug into this vast community? Next slide, let's talk about different work streams. Over to you, Stan.
Thank you, Gia. Thank you, everyone. This has been fantastic. And listening to the panelists here, we were joking with Gia, when you get stuck in theater, you start by asking, why did I choose to do this case? Then you ask yourself, why did I become a doctor? And by the time you are stuck calling, you're asking yourself, why was I born? I'm sure surgeons here can relate. Now, we have heard, and as I listened to everyone speak, Dr. Riara and the youngest in the team, I was reminded of the French philosopher Frantz Fanon, who said, every generation must discover its mission and either fulfill it or betray it. If the evidence given by Ali is anything to go by, I think from the surgical fraternity, from the leadership, from the Council of Governors, this is the generation that has decided digitizing health equity is our mission. Yes, we must now fulfill it or betrayed. But betrayed, we can't. So what we've done is look at these strategic work streams that each of us can plug into, because then when we plug into any of these, we can decide when the cameras come down and the conference is closed, what is the action point and what is the follow-up mechanism. You can see from my extreme left, we have infrastructure and connectivity that has been belabored by speaker after speaker. Then we have data and cross-border collaboration. Then we have outcomes and protocol development. Then we have budgeting, finance, and scale. And we have workforce and training strategy. We are going to request, if I have members from the protocol to help me with this, we are going to ask ourselves to sign off and commit for the leadership here from the Surgical Society, from the Council of Governors, and all the stakeholders, at least commit to any of these streams, and then we have a follow-up mechanism so that we can scale forward. This is an exercise, and I will ask, where is President Mwachiro? Where is fantastic CEO, Council of Governors? His Excellency, Professor Nyong'o, Dr. Riara representing His Excellency. So there is a pen, and we will sign off which stream we are going to pick from. So the leaders will lead us in signing that, and then all of us are called upon to sign up to one stream. And the Surgical Society and the Council of Governors will follow through with this stream. There we go. Let's give a round of applause to Prof as he comes. Can anyone guess where Prof is going to commit to? Thank you, Prof. So everyone has a sticker note. You write on a sticker note and then you come and stick it against the stream. Round of applause to Prof. He committed to infrastructure and connectivity. Everyone else, there's a sticky note next to you. Please sign off. And now, Mike, maybe you should close your eyes. Of course, what do surgeons do other than track outcomes and make sure the protocols are well developed? Madam Mary Muiti, here is the other person who knows Giaki. Yes, Madam Mary Muiti, CEO, Council of Governors, data and cross-border collaboration, fantastic, how thematic. Actually, she has committed to 2 workforce and training strategy. Thank you, CEO. Thank you so much. The gods are saying, Dr. Ganda, you're up next. What do you commit to? Which stream do you commit to? Any takers, any guesses? Go down to 1%. Budgeting and finance. Round of applause. Mike, who is committing next? Hey, Dr. Riara, round of applause. Round of applause. It was today I learned about erect lateral pelvimetry. So Dr. Riara has committed to infrastructure and connectivity and workforce and training strategy. Round of applause to Dr. Riara, representing His Excellency Governor Mudhomi Juki from my neighboring county of Tharaka Nithi. Thank you very much. Ben from Liquid Telecom. There's no solid telecom. Infrastructure and connectivity, of course. Round of applause to Liquid Telecom. Thank you so much. Shannon, are you next? Shannon will commit to everything and then I give her the mic. She'll commit to everything, then I give her the mic to close.
Mike, really quickly. I'm going to commit to every single work stream. So I'm just going to put this on and commit to strengthening Kenya altogether.
Round of applause to Shannon. And then once she's done, Mike. A round of applause to Dr. Gakombe. I can guess where he will commit. Someone said data. Oh, is there something like EHS? All of them. Round of applause to Dr. Gakombe. Private sector, well represented. Thank you, Dr. Gakombe. So he will sign all of them. Wow, thank you so much. Dr. Moada. Yes. Commit to subtotal. Workforce and training strategy. Fantastic. Very thematic. Excellent. Allow me to hand over the mic to Shannon to wrap up for us. Okay. Wow. I didn't know the attention was this deep. Jihia, who won the money?
High five your neighbor and say money. Aye. High five your neighbor and say money. Ladies and gentlemen, I am a man of my word. I am supported by Shannon and the wonderful people at the Surgical Society of Kenya. Next slide, please. Next slide, please. Now join the quiz. So here's, don't go before I tell you. Don't. So please put a name that we can verify because there is actual money. Number 2, there are going to be 5 questions. Each question is 20 seconds. Okay? At the end of it, it's fastest finger. So you can get all of them, but someone was faster than you. Fastest finger wins. There is a form 34B that will come at the end with the name and the time that you took to answer. Are we ready? Usipoteze pesa bure. 13. The pool is small. You never know. You might guess and guess faster than your neighbor. 19. I see Simon has, you put all your names and the title. I'll count from 15 down to 0, then we'll start the quiz. Are we set? 15, 14, 13, 12, 11, 10, 9. Ready? 8. Oh, now it's serious. You thought I was joking? 7, 6, 5, 4, 3. The swim, it's becoming Lake Victoria. We started with a pond. We are now at 33. 2. Kama hauoni jina yako hapo, if you don't see your name, you can. We are at 35. Anyone else? Anyone else? I should teach my pastor this. It's a good way to ensure offerings have all come. Anyone else? Sawa. I want us to finish our 5 minutes. I'll be done by 6 o'clock and someone will have money from Buta. Wonderful. Next slide. All of this were handled here. According to the Lancet Commission, approximately how many people lack access to surgical care globally? It's on your phone. The question is on your phone. You logged into Slido, it's on your phone. Only 11? Are you guessing? Only 20? Correct answer is it's coming. Click until there's a blue color. 5 billion ready. Hey, watu hata watilii simu jameni. Next question. What does MIS stand for? What does MIS stand for? My panel of excellencies have said they don't want to embarrass themselves, so they're not participating. But I'm sure you've told your secretariat, ensure your pesa inakuja kwetu. MIS, what does it stand for? 87% said minimally invasive surgery. Let's see. That is correct. Number three. Where was Proximie founded? Pom, 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 pom. Maybe it's in Kenya, like M-Pesa, yeah? Yeah? Possible. I've realized people are not even smiling. 93% think it's the United Kingdom, and it is. 2 more to go. Can you be the fastest finger? Number 4. From Jutura H, how much cost can a patient save by undergoing minimally invasive surgery? It's almost the last thing he said. Almost. Mwahaha. Mwahaha. Hey, 15,000. 15,000, is that the answer? Ready for the last question? Twende kazi. Ya mwisho. Makueni was the first. Haha, singeuliza hiyo. Which was the second? Hapa. Kulikuwa na some hints. There were hints here and there. Perhaps you picked on it, perhaps you did not. Okay. 63% said Mwabadha. Are they correct? Mwabadha. Are you ready to see who won the money? Next slide. Sasa Mudoka. So just because I know, is this Mudoka? Now, because he might have been biased, he's biased, we agree. Neurosurgeon unajua yeye ajui competition. Neurosurgeon yeye lazima ashinde. Mudoka, all protocols observed. Allow me to give number 2. Wajiro, Wamwaneki. Shannon, come and give money from Buta. Money from Buta is not 1. Too much. It's not 2. It's not 3. It's not even 4. It is 5,000. Ready! Congratulations, Wajiro Moneki. And just because, when I have the microphone, okay, pick a picture. Okay. It's because we are classmates with Wajiro. I think, wonderful. High five, Wajiro. You have done. There's no leakage. Yeah, she was my classmate. We haven't met since 2011. That's true. That's true. Ready for Wajiro? I have officially been invited to Open Fences, yes, tomorrow. Wonderful people. It has been a privilege. The work that you have seen that actually saves lives, I want to thank you all for taking time to come to this side event. Shannon, you're the one to do vote of thanks. Me, I was just to give money. But I want you to thank you for sharing your time with us, and I'll hand it over to Shannon.
And if I may, on behalf of Proximie, the Surgical Society of Kenya, the Kenya Education Network, KENET, Tony Blair Institute for Global Change, Makueni County, the British High Commission of Nairobi, and Tharaka Nithi County, we want to say thank you for attending, but for the Council of Governors especially, you have made it possible for us to scale. Devolution is a success, especially in health, and we will stand behind you to make this scale. and make you the pride of Africa. Thank you so much to everyone for coming. Oh, so I also want to just really quickly recognize Honorable Inda Kijome, the Deputy Governor of Meru County, is with us. Can you please stand? Oh, thank you very much for joining us, and we really appreciate it. You want to just say 2 words really quick?
Oh, that's a surprise. Thank you so much. I appreciate the talk that has been done here, Madam CEO. I actually saw in our governor's CEC forum that part of our team was here and that they were experiencing a live surgery. I think, yeah? So we quickly ran here. We were in the other room where we were enjoying a discussion on the feeding program. Yes. So we had to quickly run out and come and see for ourselves. Okay, fortunately, I think this is what is on screen. It's something else. It's taking medical into the next, the future is digital. So we are really looking forward to partnering with external partners to also be able to train our own doctors to be able to do such surgery, and even doing trainings on new frontiers in medicine.